Oh, okay.
So CVs are there. If you can introduce, it will be good. Or if you want me
Our
to
program
tell,
goes like,
yeah,
our program goes like
yeah.
Dr. RSV, our Secretary IEP, will be making brief inaugural remarks. And after that, if required, I'll talk for a minute or so. Subsequently, we will hand over the program to you, and you will be coordinating the entire program. Is
Yes,
that all
sir.
right, Dr. Amarnath?
Yes, sir. Yes, sir. Sure.
So,
We are ready.
yeah, before each and every topic, yeah, good morning, sir. Dr. Anurag Bajpayee, sir. Good morning.
Sir. How are you?
Yes, thank you, sir.
Good morning. Yes, Dr. Sirisha.
Morning, sir.
Morning, sir.
So, first presentation will be from Dr. Ria, sir.
No, it will be from
No,
Dr. Anurag Bajpayee.
The number you have dialed is currently
Dr. RSV, are you available? Dr. Sri Krishna?
Morning, everyone. Bhaskar sir, are we good to start?
Yeah, RSV.
morning, sir.
Yeah, we'll start the program.
I'm just looking for Dr. Bhaskar. Bhaskar sir, once you're ready, just let me know. We can begin.
Yeah, we are ready. We are all ready, waiting for you. Dr. RSV, see that the YouTube recording starts at actual presentation side.
Sir, it's already live, sir. Already started YouTube, I
On
think.
YouTube. So what's happening?
Yeah, it is showing live.
First 10 minutes is very non-stop, and people may get disgusted and they may switch off YouTube.
Yes, yes. Host, can you unmute other people, please, host? There is a disturbance from other. Sorry, mute other people, other than the panelist.
RSV, we are ready. The problem is Dr. RSV is not in town. He's in
Yes, sir.
forest.
Now I can. Yeah. No. There was some issue with unmuting it.
Okay.
I think now we are good to start. This meeting is also
Yes,
live
sir.
on YouTube. I think now we can start. Just give me 1 second, sir.
Amarnath, Dr. Raghupati sir is there, I believe.
Yeah. Morning, everyone, and welcome to today's IAP Twin Cities branch symposium on pediatric endocrinology. I bring greetings from the holy city of Sri Salem. But the advantage of technology is that it's able to connect all of us on a virtual platform. And a big advantage that we can get the stalwarts in the field interact with us directly at a time of our convenience. IAP Twin Cities is committed to ensuring the best of academics all through the year, and big thanks to the entire executive board who is making it happen under the leadership of our president. I take this opportunity to welcome you all for the IAP Central Zone Pedicon 2022. Today is the last day for registrations, and in case you're watching it today and not yet registered, please do it by the end of the day today. There are more than 600 registrations, and probably the first time ever that we have to close registrations 1 month prior. And we are making sure that every one of the delegates has a very memorable experience at the conference. I now hand it over to our president, Dr. Bhaskar sir, for his inaugural remarks. And I also thank all the faculty, esteemed faculty from across the country who have joined us here at Hyderabad on this virtual platform for a very interesting symposium on pediatric endocrinology. I hand it over to Bhaskar sir. Over to you, sir.
Yeah, thank you, Dr. RSV, for making very good opening remarks. Respected faculty members, Dr. Raghupati sir, I hope he's there, he's participating. Dr. Anurag Bajpai, Dr. Riaz, and Dr. Hemchand Prasad, and our faculty from Hyderabad, Dr. Amarnath, Dr. Rahul Reddy, Dr. Linata, and Dr. Kusuma. And dear participants, a very good morning and welcome you all to this 6th IAP Twin Cities branch symposium on subspecialties. And we are obsessed with conducting these symposia every month on first Sunday of every month. And this is the 6th one which we are doing on pediatric subspecialties with a theme of getting only one very important disorder of the subspecialty. Like today, we are choosing thyroid disorders. So every time we are choosing one topic from subspecialty during the first 4 lectures, followed by the 40 minutes is for other disorders in the subspecialty which are relevant to the practitioners. And I proudly say this is the first time we are having 4 guest speakers from other states other than Hyderabad. It's a pride to IAP Twin Cities branch, and credit goes to all of you, particularly Dr. Amarnath. As Dr. RSV Sri Krishna said, we are organizing IAP Central Zone Conference on 1st, 2nd, and 3rd July. It comprises of 5 states, UP, MP, AP, Telangana, and Chhattisgarh. Our venue can accommodate up to 300 to 400 delegates, not more than that. So we are compelled to close the registrations by tonight. But interestingly, we have 14 workshops, 14 workshops, never ever before in the history of IAP, Andhra Pradesh and Telangana. And all are very competitive, very interesting, and very useful. For them, registrations are open, and registrations for the main conference is not mandatory for those who are willing to participate in workshops. I am sure some of our faculty members who had returned just from their holiday pleasure trips, like Dr. Linata and Dr. Hemachan, probably they are in the transition period from pleasure trip to the academics. I'm thankful to them. And as well, I'm grateful to Dr. Raghupati sir, who is recovering from his minor ailment. I wish and request him to participate in this symposia because you are one of the luminaries in the field of pediatric endocrinology. And personally, and on behalf of IAP Twin Cities branch our special thanks to Dr. Amarnath Kulkarni. He's been after this symposium this last 4 weeks, and I'm sure because of his involvement, we got this luminous stalwarts of the faculty members. He's a great person and an inspiration to our IAP Twin Cities branch and Telangana state. Thank you, Dr. Amarnath. And once again, I thank all the participants, particularly faculty from Hyderabad and faculty from other states, for being with us. And it shows your zeal and enthusiasm to spread your knowledge and skills to all the participants. Because it's a Sunday morning, supposed to spend with your family, to attend family functions. Despite that, you had come. We are very grateful to you all, sir. And special thanks to all the participants. And I always believe those who attend the symposia and the workshops are there. They are the true academicians, and they are the truly interested in learning the academics. So, wishing you all a great learning experience. Thank you all. Long live IAP. Jai Hind. Thank you. Over to Dr. RSV. Yeah, if he's not available, now I request our Dr. Amarnath Kulkarni to coordinate and to conduct this program from now onwards. Over to Dr. Amarnath.
Yeah, thank you very much, sir. We pray that our IAPTCB and PATS Central Zone Conference will be excellent, and we'll enjoy that. We would like to thank from our bottom of heart to the IAPTCB for giving this chance. Before I start, we'll start with a small prayer. As Raghupati sir is one of the stalwarts, and we can say Pitamaha of Pediatric Endocrinology of India. Yasya smarana matrena jnanam utpadyate swam sa eva sarva sampattihi tasmat sampujayet gurum. The meaning goes like this: if you remember those people, the pediatric endocrinology will be flowing into you. So sir is like an ocean, just I'm a drop. So there is a lot of difference. I am not so great. Whatever is there, we are still small buds, just budding. So first of all, I would like to thank all the guest faculty who have agreed in spite of holiday mood and being the summer. I would like to thank again and again to Anurag Bajpai sir. He's from Kanpur, and Riyad sir is associate professor from Government Medical College, Trivandrum. Dr. Hemchand sir, he's the editor of our Cape News and has done many works. He's from Chennai Mehta Hospital. And our dear colleagues, I'm the most junior out of all the faculty. There are many seniors. Dr. Lineta, when I was doing DCH, she was a consultant, and I have learned a lot of things from Dr. Lineta. Dr. Shirisha, she is my senior, Raghupati sir student from Rainbow Hospital, and Dr. Rahul uh, from the Fernandez Hospital in Ankura Hospital. Now I request our Riyad sir, my senior from Indira Gandhi Institute and associate professor from the Government Medical College, Thiruvananthapuram, to moderate the first half of the session, and second half will be moderated by the Dr. Lineta Jikaddi madam. And we pray that Raghupati sir, in spite of his illness, he is on the bed. He is very minor illness, so he is listening to our lectures and CME. We are grateful to you, sir, and we pray that you will recover fast. Over to you, Riyad sir.
Thank you, Dr. Amarnath. Respected President of IAPTCB, Bhaskar Shenai sir, Secretary Dr. Sri Krishna, our most respected Guru Raghupati sir. We call him a banyan tree, who is actually the force or the spirit behind all of us. I think everyone in pediatric endocrinology consider him like the leading light. So even though he is not talking to us today, his presence gives us all the grace which such a solemn function needs. And now it is my turn to invite one of the most versatile and energetic speakers in pediatric endocrinology, Dr. Anurag Bajpayee. His classes on pediatric endocrinology are so fascinating. I think all of us here has had a taste of it at least once. And without much ado, I welcome sir to have his deliberation on a very perplexing but most important laboratory test for each of us as pediatricians, and that is thyroid function test. Over to you, sir.
Thanks a lot, Dr. Riyad, for this wonderful introduction, and thanks a lot, Dr. Amarnath, for inviting me for this wonderful galaxy of pediatricians from across the country. Once again, best wishes to Professor Raghupati, who is the guru of all of us, and we hope that he has a quick recovery. And thanks, Dr. Bhaskar and Dr. RSP for this invite on part of the Twin City branch. So what I'll be doing today is to mainly focus about the thyroid function assessment and how it is relevant and how do we interpret the nitty-gritties and complexities of thyroid function assessment. I'll also be having a couple of slides with regards to the management of acquired hypothyroidism, as Dr. Raghupati unfortunately could not take that. So I'll just have a brief overview on this from that perspective. So we'll start off with a couple of cases which show how thyroid function interpretation, though is considered to be quite simple, can have certain implications with regards to evaluation and management.
Just a second, sir. There is a background noise. I request host to mute the other people. And just I wanted to tell that Anurag sir, when he was doing MD at AIMS, that time itself he wrote a book on pediatric endocrinology. Very great inspiration for all of us. He's doing maximum work. He's having very international level of work, and many classes he's conducting, and he's having a very good application and books. Hope everyone will take advantage of that. Even I also take advantage of that. Over to you, sir.
Thanks, Dr. Amarnath. So we had this 16-year-old boy with obesity who was quite obese. The height was reasonable. The BMI was 46 kilogram per meter square and was found to have a slightly elevated TSH of 7.5 advised thyroxine. This is a common presentation, and often people feel that now we have got the cause, the child will improve. What happened 1 year later was that there was no lifestyle intervention. The child now presented with frank diabetes and steatohepatitis. So what is very important to understand is that the proper interpretation of this TSH level, which I'll discuss subsequently, is the effect of obesity and not the cause of obesity, is very important, and that can cause a lot of confusion in that perspective. Another situation, 12-year-old girl with septic shock was found to have a very low level of TSH. Free T4 was slightly high, and then everybody was getting confused whether this is thyrotoxicosis or is it a normal part. And we know that when we are interpreting the thyroid functions in a setting of illness, there can be a lot of confusion in that regards. So T3 in this scenario was found to be low, which basically will indicate that this is more like a non-thyroidal illness rather than actual hyperthyroidism or thyrotoxicosis in that regards. So what we need to understand is that thyroid function tests are done routinely. So whenever you are evaluating somebody with growth failure, with pubertal problems, with mental issues, developmental issues, we do thyroid functions. It is often done as part of screening tests. So we want a test which has to have a high sensitivity, and therefore specificity may be compromised. That may cause confusion in terms of diagnosis. Often we want to exclude the condition, and there are a lot of physiological variants. So there is a need of comprehensive understanding of how to do the thyroid functions, when to do, and most importantly, how to interpret in that regards. So we'll be talking about all these aspects over the next 20 minutes or so. I'll focusing about the various scenarios of the basic thyroid functions and how they have implications in that perspective. All of you can go and have a look at our website, learning.rosari.in, which has got multiple modules and validated tools about pediatric endocrinology, including free videos, lectures, as well as courses on pediatric endocrinology. Now, before we start, we'll talk a bit about physiology. Now, we all know that the hypothalamic TRH acts on its receptor to produce TSH, which has an effect on the thyroid gland to produce T4, which actually is a prohormone. Now, this T4 has to be converted into T3 and it is co-secreted with thyroglobulin. So, thyroglobulin is a reliable marker of functional thyroid tissue, which I'll be discussing a bit later. Now, T4 is monodeiodinated to its active form, which is T3. Most of T4, 99.97% of T4 and 99.7% of T3 are actually bound to thyroxine globulin, and it's actually the free form which is active. So when we are assessing a total thyroid levels, be it T3 or T4, if there are variations in the thyroxine binding globulin, we may have variable results that may cause confusion, especially in the setting of estrogen use, in pregnancy, in liver disease and nephrotic syndrome, which I'll discuss subsequently. Now, this T3 then acts on its receptor to cause an inhibition. So it's like a feedback inhibition of the thyroid. So based upon this feedback response, we can really understand how to interpret thyroid hormones and TSH in constellation. So in scenarios of primary hypothyroidism, where the problem is at the thyroid level, we would expect the TSH level to go up. So the first change in primary hypothyroidism is the rise in TSH. Second would then be a fall in T4. The body wants to conserve T3 levels. Whenever your T4 goes down, the conversion to T3 increases. So the last thing to fall will be T3 in that scenario. So the least important
Anurag sir, if you can use the earphone, that will be little background noise is coming, sir.
Okay, just hold on. Is it better now?
Yes, sir.
Okay.
Better. Thank you very much. Sorry.
So what I'm trying to imply is that T3 is the least important investigation in somebody who has got primary hypothyroidism. The most important is TSH followed by T4. That is something which is important to remember. Now, what will happen if you have a central hypothyroidism or a problem in the hypothalamus or pituitary? Now, this is very important because this may imply that there may be other hormones which are affected, and also there could be issues with regards to the effect of the neuroimaging problems, because there may be a CNS lesion which may be causing that. So in central hypothyroidism, what will happen is that the TSH level will fall, will not really rise. Major problem will be a fall in T4, but TSH will be normal. Now, generally we understand that if you have central hypothyroidism, the TSH should be low. But in certain scenarios, because of bioinactive TSH, the TSH may actually be normal or slightly high. But there is a log linear relationship between T4 and TSH. If T4 is low, TSH should be sky high. If you have low T4 and a TSH which is less than 20, that indicates central hypothyroidism, and that's a big message which I'll reiterate subsequently as well. Now, what about thyrotoxicosis? If somebody has got more thyroid hormone, the first thing, of course, will happen is that the TSH will go down, and then this will be followed by a rise in T4. In situations like iodine deficiency, there may be increased conversion of T4 to T3. So there will be a rise in T3, which may also happen in that scenario. So T3 becomes important in thyrotoxicosis. It has got a limited role in the setting of hypothyroidism in that scenario, and that becomes very, very relevant in that scenario. There are antibodies also which we measure, the TPO antibody, which basically tells us about the damage to the thyroid gland, and the TSH receptor antibody, which may be blocking or stimulatory, which will give a role in the setting of thyrotoxicosis largely, and thyroglobulin antibody, which becomes very relevant when we are assessing thyroglobulin in differentiated thyroid carcinoma, which I'll discuss a bit later in that setting. So when we talk about thyroid functions, we're talking about actual thyroid hormones, T4 and T3, the pituitary signal TSH, immunity signals in the form of TPO and TRAP, and finally thyroglobulin as a surrogate marker in that regards. The most important and the most commonly done thyroid test is, of course, TSH. So we need to understand the variation of TSH. There is a diurnal variation of around 40 to 50% in TSH, with peak value at around 12 to 4 a.m. and nadir around 10 to 4 p.m. However, there is a lot of biological variability. So therefore, this diurnal variation becomes less relevant. So even though there is a 40 to 50% variation, you can do TSH at any time of the day. If you have a patient who is coming to you in the afternoon, don't ask them to come back again in the morning, because that can cause more confusion in that scenario. Importantly, the intra-individual variation in TSH is substantially lower than the inter-individual variation. And this is relevant because if you have an individual, they have a specific set point for TSH. So if for an individual, your TSH is around 3.5, if it rises to 6 becomes more important. But if somebody's baseline TSH is somewhere around 5, it may actually have a lot of variation. So when we talk about TSH interpretation, we have to look at the factors of the age, previous TSH which is available, ethnicity, and as I discussed, BMI or obesity also becomes relevant from that perspective. And that's quite significant scenario to look at in that regards. Now, TSH level changes with age, and we all know that there is a huge rise in TSH at birth because of the cold stress, and therefore we need to use higher values, which will be covered in congenital hypothyroidism. Just to give a brief idea, if your TSH is more than 40 in the first week, 20 in the second week, and about 10 in the third week onwards, you need to worry about the possibility of hypothyroidism. If levels on the other hand are less than 20 and 10 for first week and beyond 2 weeks, you're pretty much reassured in that regard. So you have to use age-specific cutoffs. From 1 year onwards towards childhood, the TSH is around 6, which is slightly higher than the adult cutoff of 4.5. And as age progresses, we use a much higher cutoff of 8 overall. So in children overall, 6 is an upper limit, and 6 to 10 is what is considered to be a subclinical hypothyroidism in that perspective. Now, what are the issues that one faces with regards to the TSH evaluation? One, of course, is that it cross-reacts with other glycoprotein hormones. So if you have very high levels of HCG, there may be issues when we talk about evaluation. There is also an important factor that there is a variability of biological function, and that depends upon glycosylation. The more glycosylation, you will have greater biological activity, less glycosylation, less activity. This becomes relevant in what I was talking about in the scenario of central hypothyroidism, where you have a bioinactive TSH, and therefore, even though we expect TSH to be 0, TSH may actually be detectable, but that will be normal, low, and inappropriate for the level of T4. There is also a concept of macro TSH, which is something like macroprolactin. So this is again a bioinactive TSH, but because of a large molecule, it is measured as a big size. So if you have very high TSH with no clinical features, you have to consider macro TSH in that perspective, and that becomes important, and you can use pegylation studies in that scenario. So now you have a 10-year-old girl with hypothyroidism on a high dose of thyroxine. TSH was 54. Earlier levels were normal. There is good adherence. Child is euthyroid. Now, what has happened all of a sudden that the TSHs go up? So, of course, you will talk about adherence, medication, illness, other factors, but of course, analytical issues also come up in that scenario. Repeat TSH was done, which was normal, and this is what is known as a carryover effect. So, if the previous sample that was measured had a very high TSH level, and now if you look at the level in the second patient, the levels may go up really high. So this is a carryover effect. So if you have a discrepant TSH level, always repeat it. Do not get confused that suddenly the level has gone up in that perspective. 12-year-old boy on routine screening was found to have a TSH which was high. FT4 was normal. Child was euthyroid and TPO negative. So no clinical scenario. On treatment, the child suddenly developed features of thyrotoxicosis. So again, this is an analytical issue which we discussed, and this was a scenario basically of a macro TSH. So if you have high TSH, which is not fitting into your clinical scenario, once you exclude the other causes like autoimmunity, think of a macro TSH in that regard. So these subtle features will become important, and you can do a pegylation study which will give you the right scenario in that perspective. Now, this is the case I was talking about. 14-year-old boy with craniopharyngioma, follow-up after surgery. FT4 is on the lower side. TSH is 12. Now, this is important. We said that anybody whose FT4 level is low should have a TSH which is high, at least about 20. If the TSH is 12, below 20 in that scenario, this suggests a possibility of central hypothyroidism. And where is this TSH coming up? This is basically a bioinactive TSH. So this TSH is there, but it is not acting because the hypothalamus and the pituitary are not working well. They are producing a is not glycosylated in that scenario. So even if your TSH is up to 20 and FT4 is low, this could still be a central hypothyroidism in that scenario. What about thyroid hormones? When we assess thyroid hormones, we look at total or free hormones. Total hormones are 1,000 times more as compared to free hormones as discussed. They are, however, affected by thyroxine binding globulin. They have got a more robust assays in that regards, not affected by heparin, but they are affected by non-thyroidal illness. So if you are considering scenarios where the binding protein may be variable, go for a free hormone rather than a total hormone. So this becomes important in that scenario. So just to summarize, if you're looking at somebody whom you're thinking of hypothyroidism as a diagnosis, do both free T4 and TSH. That will give you both central as well as primary hypothyroidism. If you're thinking of thyrotoxicosis, do a T3, free T4 and TSH, because that will give you a complete picture in that regards. Now, as discussed, most of thyroid hormone is bound to thyroxine binding globulin, which is produced by the liver. Around 75% of binding is done by TBG. A reasonable proportion binds to albumin. So conditions affecting albumin will also have an effect, which is again using the liver production. So liver disease and nephrotic syndrome. And finally, transthyretin, which is more of a local protein in that scenario. Conditions which are associated with increased TBG level, like estrogen exposure in the setting of estrogen progesterone therapy, in the setting of pregnancy, will have a falsely high level of T4, normal free T4 and TSH. So if your T4 is high, TSH is normal. This is not always a thyrotoxicosis. Do an evaluation of free T4 in that scenario. On the other hand, testosterone treatment and glucocorticoid will suppress TBG, and they will result in a picture of low T4, normal free T4 and TSH. So if you have a confusion in that regards, evaluate accordingly in that scenario. Drugs like heparin, NSAIDs, and some anti-epileptic drugs disrupt the binding of T4 to TBG. So suddenly you will have a very high levels of T4 in that scenario, which will cause confusion. So whenever you are assessing total thyroid hormones, beware about scenarios like estrogen, testosterone therapy, liver disease, and nephrotic syndrome, which may alter the binding potential and cause confusion in that regard, and that becomes important in that scenario. So we now have a 10-year-old girl who had complained of poor concentration. Height was not that much affected, clinically looked euthyroid. TSH was low, T4 was also low. So I discussed earlier that if your T4 is low and TSH is also normal, think of central hypothyroidism. So the treating physician had advised an MRI and a cortisol level to evaluate for central hypothyroidism. But the question is it really hypothyroidism? So whenever you have a T4 level which is low, start thinking of a possibility of thyroxine binding globulin abnormalities. And what we found was that free T4 levels was normal. So this was a TBG deficiency. So the ideal investigation in hypothyroidism is free T4 and TSH rather than T4 and TSH in that scenario. 16-year-old girl with hirsutism and oligomenorrhea evaluated, found to have high T3, high T4 and a normal TSH. Clinically euthyroid, referred for evaluation. So again, this is a scenario where you think of a TBG abnormality and ask the history. What we found that this patient was already on estrogen and progesterone, and that was causing a confusion. Free T4 was normal. So if you have discrepantly high T3, T4 and a normal TSH, think of a TBG excess because of estrogen. Now, once you have ordered FT4 and TSH, how do you interpret? And this slide is going to be the most important because this will focus on the every aspect of it. So on the left-hand side, you can see that there is a curve which shows that as soon as the FT4 level goes down, TSH should shoot up dramatically. And if your FT4 is high, TSH should be 0. So low FT4 means a high TSH. Above 20, this is classical primary hypothyroidism. But if your TSH is below 20, that is low, normal, or inappropriately normal, this becomes central hypothyroidism, and that is very, very important thing to remember in that scenario. So TSH below 20 and a low FT4 is central. You have to think of an MRI head. You have to think of cortisol. If your FT4 on the other hand is high and your TSH should be 0, which is classically thyrotoxicosis, but if your TSH is high, you have to start thinking of a TSH producing adenoma, which is very, very rare. So always look at both FT4 and TSH. Don't just do a thyroid hormone like T4, because then you will be confused in that scenario. We have developed a thyroid interpreter, which based upon the inputs one puts in, provides information about the diagnosis, evaluation, and management, available as part of our Mediclasses application. We'll discuss this a bit later as well. So now if you're suspecting hypothyroidism, look at free T4. If free T4 is low and TSH is about 20, this is the most common primary hypothyroidism. If TSH is below 20 and FT4 is low, this is central hypothyroidism. Look at MRI and cortisol level from that perspective. If your free T4 is normal and TSH levels are below 6, this is normal. More than 10 is primary, 6 to 10 is the borderline situation. So this could basically be that we are talking about a subclinical hypothyroidism. So if there is TPO positivity, there is goiter, there is family history, and there is a girl child, think of treatment, otherwise follow up. So the big message is do both FT4 and TSH. If FT4 is low and TSH is not elevated, this is central. If FT4 is low and TSH is high, that's primary. If FT4 is normal and TSH is more than 10, consider treatment. Less than 6, normal. 6 to 10, look at these risk factors, particularly TPO. Non-obese, start treatment. Obese, observe. That would be the message in that scenario. So finally, how do we interpret all this? If you have low TSH, low FT4, low FT3, this is central hypothyroidism. Even if FT3 is normal, this remains central. There could be a rare scenario of high FT3 with a low FT4 and TSH. This is T3 treatment, not common in that regards. If your FT4 is high and TSH is low, this is thyrotoxicosis. If you have a normal FT4 with a high FT3, it is T3 toxicosis. We'll use all these in a case scenario towards the end of the discussion. On the other hand, if your TSH is normal, this is important, normal TSH with high FT4, it means that there is something wrong. There's a TSH adenoma that you have to rule out. If the FT4 is low and TSH is normal, this is central hypothyroidism. Again, TSH may be up to 20 in that scenario. If your TSH is high and FT4, T3 are normal, this is subclinical hypothyroidism. And if you have FT4 low, this is overt hypothyroidism. So if you combine FT4 and TSH, you will get your diagnosis, and it becomes absolutely important. Just to go through a few cases to illustrate this scenario, we have this child whose FT4 is normal, TSH is slightly high. So what is this? This is subclinical hypothyroidism. If you put in our thyroid interpreter, it will just ask your information about FT4 level and the TSH level, and then based upon that will just inform us that this is subclinical hypothyroidism. We do not need to do much workup, do a TPO antibody in that scenario. 18-year-old boy with lethargy, FT4 is low and TSH is 18. So what is this? If we put these figures, what we're looking at is that you have a low FT4 and a TSH is below 20, which basically gives you a direct implication that this looks like a central hypothyroidism. You do not stop here, do an MRI, do a cortisol level in that scenario. 14-year-old girl with tremors and weight loss, FT4 is high, TSH is low. So what are we looking at? If you look at this picture, high FT4, appropriately suppressed TSH, this is classically a thyrotoxicosis. Evaluate based upon the clinical scenario versus for Graves versus thyroiditis. 12-year-old boy with weight loss, what we are seeing is that FT3 is high, FT4 is normal, and TSH is low. So this is a situation of T3 toxicosis, in which your T3 may be high because of iodine deficiency. You have to be aware about this condition. If you just do FT4, you will get confused. So whenever you are having a scenario of thyrotoxicosis, also do a FT3 level in that regards. Final case scenario, 17-year-old boy with headache and weight loss. FT4 is high and TSH is normal. This is a very unusual situation. High FT4 and a normal TSH would mean that this is not coming from thyroid, it is coming from the pituitary, or there is resistance to thyroid hormone. So if you look at in this scenario, what we are really looking at is that we have got a FT4 in the higher range and the TSH is detectable. So this becomes the TSH dependent thyrotoxicosis. Think of a pituitary adenoma or a pituitary resistance in that scenario. So this is about the part on the thyroid functions. We can take a few questions here before we go ahead with thyroid acquired hypothyroidism, just a couple of slides. Or Dr. Amarnath, how do you want me to go on to that?
So I think there are a few questions.
Those questions, and then I'll quickly go through the acquired hypothyroidism part. That will be a couple of minutes. Yeah. So,
okay, sir. So the question is, in the infant with primary hypothyroidism, what is the effect of levothyroxine dose on monitoring of the levels of TSH, free T4 and free T3?
That's a very, very relevant question. And what we need to remember is that if we talk about congenital hypothyroidism, they have been exposed to hypothyroidism throughout life, and they have got a reset hypothalamic pituitary axis, especially in the first 2 years of life. So the key parameter to follow on treatment is the free T4 level. So when you start treatment, you expect that the FT4 level should become normal or high by 2 to 4 weeks of life, and then you follow up FT4. TSH will take much longer to come down because one, its half-life is longer, and second, there is a reset HPT axis. So do not rely on TSH in the initial phase. FT3 is of no use. I wouldn't recommend doing a FT3 on follow-up. FT4 and TSH, especially for the first 2 years, with major focus on FT4. And then from 1 year, 2 year, you can rely mainly on TSH if the axis has already been now reset in that perspective.
Thank you, sir. Next question is, for neonatal screening, do we do free T4 and TSH or TSH alone?
That's again a very important question. I didn't touch that much because there's a talk on congenital hypothyroidism, but just to illustrate, when you talk about neonatal screening, the major aim is to identify primary hypothyroidism. Central hypothyroidism is rare. Most cases of central hypothyroidism are actually associated with other clinical phenotypes like micropenis, midline defects. So in these scenarios, TSH alone is used. If you use free T4, the cost will go up a lot in terms of screening. So if you have a routine screening, TSH alone is the strategy. If you are thinking somebody is actually having hypothyroidism, there's a high pretest probability, then you do free T4 and TSH. So TSH is the screening strategy that we follow and most countries now follow for primary hypothyroidism screening in neonates.
Sir, one last question. How about in Down syndrome with TSH21 with a normal free T4 in a 2-year-old child?
Yeah. So this is a very, very relevant scenario, and we see that trisomy 21 is associated with a number of effects in terms of thyroid functions. We do see thyroid hormone resistance, we see thyrotoxicosis, we see subclinical and overt hypothyroidism. Mild TSH elevations up to 10 do not require treatment, so don't get too wary unless the antibody is positive. But if the TSH is 21, we would have to go ahead with treatment in that scenario, even if the FT4 is normal. So again, follow the routine dictum. If your FT4 is low, TSH is more than 20, primary treat. FT4 low, TSH less than 20, this is secondary, do a MRI cortisol and treat. FT4 normal, TSH more than 10, treat. So this is again a same scenario in that regards.
Thank you, sir. Now I think we can move forward to the next part.
Anurag sir, I wanted to just 2 minutes you give. Just we wanted to know what are the research projects you have taken on thyroid, which you are doing a lot. That one.
Yeah.
And second thing, in ICUs, we get a lot of this NTIS. So how to treat if FT4 also low? If FT4 is normal, we'll not going to treat the non-thyroid illness syndrome. But if FT4 is low, how to treat? Thank you.
So I think just to go one by one in terms of your question. So one, with regards to our research projects, which we're doing in terms of hypothyroidism, there is one which we already published, which was with regards to the overall impact of subclinical hypothyroidism and obesity, and how do we go ahead in terms of how do we, whether they require treatment and whether they have an impact or not. So what we found interestingly that 40% of obese individuals have a TSH between 4.5 to 10. When we like to evaluate whether it is going to have an impact or not, what we found that high TSH was an independent predictor of steatohepatitis. So if you look at, if you exclude BMI, if you exclude fat, the TSH alone can predict in a multivariate model the development of steatohepatitis. So what I'm trying to say is that even though this high TSH may be an effect of obesity, it is worsening the obesity complication. Now, whether treating this is required or not is a secondary question, but then the subclinical hypothyroidism itself has an impact with regards to the overall aspect of fatty dyslipidemia as well as non-alcoholic steatohepatitis. This is one finding which we have published. The second one, which is under consideration and publication, is the impact of thyroid treatment on bone age advancement and the chance of effect on growth. Now, many girls present to us late with severe short stature for acquired hypothyroidism. Once we start treatment, suddenly they start to bounce back. Their height starts to increase rapidly. But what we have seen is that the bone age advances much more rapidly, and that really causes a lot of confusion, and that can have an impact with regards to a growth acceleration. So what we suggest that we need to follow bone age very carefully, and there may be a potential role of thinking of GnRH analog in that scenario. This is the second publication which is in Anvil. The third is the thyroid interpreter. So we are validating a thyroid interpreter, which I have shown here, and it has been shown to be a very valid tool to evaluate and assess thyroid functions in that scenario. So these are the mainly ones which you're focusing on thyroid in that regards. Now, coming back to your interesting question of non-thyroidal illness, this is definitely a scenario which is very, very common and something which we have to worry about. So I'll just show you this slide, and this will summarize the entire picture. Because so what happens in non-thyroidal illness is that body wants to go into a shell. If you become sick, you do not want to waste your energy in things like thyroid. You want to conserve energy in fighting the infection. So the normal response in the initial phase is that body goes into a central hypothyroid-like state. Your T4 level goes down, TSH level goes down, T3 level goes down. This is because of the decreased conversion of T4 to T3 and a CNS suppression of TSH. So in acute stage, you will have low T3, low T4, low TSH. This is central hypothyroidism. While when you're recovering, you will have a high TSH and a normal FT4. That's more like a primary hypothyroidism like picture. So the big message is that if somebody is admitted, do not unnecessarily do a thyroid function unless there are clinical features. If you do, then look at FT4 and TSH. If your TSH in this scenario is very, very low, less than 0.005, as I was showing in the second case in thyroid function, then this could be a thyrotoxicosis. So look at FT4. If FT4 is also high, this is thyrotoxicosis. Remember, in illness, FT4 should be low. So if your FT4 is high despite illness, this is definitely abnormal. If FT4 is normal, then you just need to follow up in that scenario. Then if your TSH is within 0.05 to 0.3 range, so if it is very suppressed, then think of thyrotoxicosis. But if it is in the mid range, this could actually be a non-thyroidal illness, or rarely this could be a central hypothyroidism. Then you look at cortisol. If your cortisol is low, now illness cortisol should be high. If your cortisol is low, this is central. If cortisol is high, then this is a normal response in that scenario. What about TSH 0.3 to 4.5? Nothing to worry. This is normal follow-up in that scenario. If TSH is 4.5 to 10, do not do anything. Repeat after a week. If it's more than 10, now this is important. You expect during illness, TSH should go down. If your TSH is more than 10, this is very significant. Look at free T4. If it is low, treat. If it is normal, repeat. So I think this is a summary of your question just to revise again. The treatment is required only if your TSH is more than 10 and FT4 is low. This is very, very important. If your FT4 is normal and TSH is more than 10, better to wait for some time. While if it is very, very low, exclude thyrotoxicosis. If it's marginally low, rule out central hypothyroidism doing a cortisol level. So if you do a wise assessment in terms of TSH, followed by FT4, you will get the answer for non-thyroidal illness in that scenario. Hope that answers, Dr. Amarnath, your question.
There's one more question from Ramakrishna. Yeah. Dr. Ramakrishna.
Yeah. Is it T3 high, TSH at upper limit of normal? Can this be seen in those taking thyroxine tablets? Yes. So if somebody has recently taken a lot of thyroxine tablets and they had not taken it earlier, T3 and T4 will go up quicker because they will have a shorter half-life in that perspective, while TSH takes longer time to suppress. So if you have somebody who is acquired hypothyroidism on thyroxine treatment, you find T3, T4 high, and TSH is also high, this could be part of a adherence issue that taking too many tablets at the moment.
So there is one more question regarding nephrotic syndrome. Do we need to treat the hypothyroidism caused by nephrotic syndrome?
This is again a very, very relevant scenario. So unless the TSH is very high and FT4 is low, we need to be a bit cautious because often interpreting thyroid function in that scenario may be very confusing. So TSH more than 10 and a low FT4 I will treat. Otherwise, I'll wait and watch.
Sir, we will take one more question and the rest I think we can answer in the chat box on the interest of time. So the last question is, sir, is thyroxine alone is sufficient enough in children with acute hypothyroidism with short stature? Please enlighten us.
So in an ideal scenario, if you're picking them up at the right time, there is no confusion. They will have a dramatic response to thyroxine. They will improve. Unfortunately, we see a lot of lag in diagnosis and that causes confusion because then puberty suddenly comes in. And in that scenario, GnRH analog may rarely be required. But having said that, if you pick up at the right time, thyroxine alone is the best therapy and this will give you a good response. If you're picking up somebody at 14 years of age and the bone age is 7-8 years, you will gain, but then suddenly puberty will come in and the time becomes limited. So it has to be an individualized decision. But thyroxine is the treatment clearly. Rarely you may need to combine. If you have less time, you have to buy time using GnRH analogs.
Sir, along with that, is there any role of growth hormone in this?
No role. There's no role of growth hormone, definitely. Is not at all required.
Thank you, sir. I think almost all the questions which we face as a pediatrician while interpreting TFT has been resolved. And there is a continuing opportunity to learn from Dr. Anurag Bajpayee, and I wish every one of us do use that. Thank you, sir. Thank you. For
Just a second, sir. Anurag, sir, many people are asking about your application. Can you tell about a few seconds?
Definitely. So this application is the MediClasses mobile application, which is available on the both Android and iOS store. This application has actually now been revised extensively. We now have around 50 approach pathways, 40 management pathways, and a lot of analytic tools which allow use of this practical pediatric endocrine knowledge in terms of clinical practice. So thyroid interpreter is one of them. We've got growth interpreter. We've got disorder of sexual development interpreter. We've got puberty interpreter. All you have to do is to put the data and they will analyze all the scenarios and give you the diagnosis. So this is a very helpful tool. It has got also information about how to evaluate, how to manage along with knowledge bank. So quite extensive information is available. It's in the form of MediClasses application, which is available on both Android and iOS tools. So you can all go and have a look at it. It's complementary in the initial phase and there are a lot of functions which remain complementary. We have done 3 publications on this regarding bone age assessment, a very simplified tool for bone age assessment. We have done one on growth interpreter with very valid inputs, and recently has been published on DK, which provides personalized guidance based upon the actual pH, carbon dioxide, bicarb level, how much fluid to give, how to evaluate. So it's available on both Android and iOS stores.
I thank Dr. Anurag sir and Riyaz sir for troubleshooting. So you have made the deficiency full and you have made the impossible possible. Sorry to disturb you on this morning, and I thank Raghupati sir also. Being ill, he is presenting his blessings are continuously flowing. Now I request Riyaz sir to present the second topic, that is congenital hypothyroidism. Thank you very much, sir. Anurag sir.
Thank you.
Dr. Riyaz sir is my beloved senior from Indira Gandhi Hospital. He has done fellowship under Dr. Raghupati sir. Presently, he is the co-author for ISPE National Guidelines on Congenital Hypothyroidism. He was the Secretary IAP Kerala 2017 to 18. At present, Executive Board Member Central IAP. And he has done maximum work, and they have introduced the congenital hypothyroidism screening in all over the state in Kerala. Thank you very much, sir. And he's also my teacher. Many things we learn apart from the academics. So non-academic part also we'll learn from him. Over to you, sir. Thank you very much for moderating the first session.
Thank you, Amarnath, for those nice words. And I think Dr. Anurag Bajpayee had made my talk much easier because all the problems regarding TFT has been discussed. And when we discuss about congenital hyperthyroidism, I bow before Raghupati sir and I start my presentation. And the first question which we ask is why screening is important, or rather why screening? Because there were, I should say, there were many clinicians who thought that we have enough clinical skills to identify congenital hyperthyroidism. But what is the problem in identifying congenital hyperthyroidism by clinical examination only is what we are going to discuss first. So this baby was identified with congenital hyperthyroidism. One of our first babies to be identified during our state-run as congenital hyperthyroidism screening program. And when you look at the baby, we can see that the baby is absolutely fine. And the only reason why the baby was recalled was the code. The initial screening TSH was 48.9. And when we examined and evaluated the child, we have seen that the TSH was more than 60 and free T4 was 6.24 and free T4 was 0.62. So we made a diagnosis of congenital hypothyroidism, started the baby on treatment. And now the baby is almost 3 years and 3 months. Her height is between the 10th centile and 25th centile. That means along the mid-parental height centile. And there is no developmental delay. So that is the beauty of identifying congenital hyperthyroidism at the time of birth and initiating treatment then and there. And why screening is important is, see this baby, absolutely fine, very good looking, but the TSH was more than 150. We can identify congenital hyperthyroidism. The only way to identify all babies with congenital hyperthyroidism is by doing a screening at the time of birth. So these two babies I met while I was under training with our beloved Dr. Raghupati. And why we should screen is we should never see such children. See, this boy was actually 4 years of age and so much stunted with all the intellectual disability. Whatever thyroxine we pump in now is not going to help the baby. So we read all the clinical features of congenital hyperthyroidism in our textbooks like coarse facies, puffiness of eyes, protruding tongue, pallor, lethargy, hypertonia, distended abdomen, umbilical hernia, prolonged jaundice, constipation, feeding difficulties, inactivity, macroglossia, white fontanelles, mottling, hypothermia. So all these should actually remain. All these should actually remain in the textbooks only. We should never see such symptoms in any baby. Because if these symptoms has once appeared, that tells us that the damage has already been done. So the only way, again and again I'm telling, is to do a universal screening for all babies. And now the recommendation, the latest recommendation from the European Society of Pediatric Endocrinology also tell us that we have to do a universal screening to optimize the developmental outcome of babies with congenital hyperthyroidism. And from the medical school itself, from the undergraduate days, we all learn congenital hyperthyroidism is the most common cause of preventable mental retardation, and we need to act on that. So there is a need of establishing a universal congenital hyperthyroidism screening all over our country. And why screening is important? Because we get the best results when treatment is initiated within 2 weeks of life, and hormone replacement within 30 days actually gives a mean IQ of 106. A delay of 3 to 6 months actually take the intelligent quotient of the baby to below 70. So That is why screening is important. I think now all of us are convinced that we need to screen every baby born for congenital hypothyroidism. How do we screen? Majority of the programs use a filter paper TSH on day 3 to 5 or a cord blood sample. So which is better? That question always arises. So it actually depends upon our scope of practice and the hospital where we work. If it is a small hospital where there are very few number of deliveries, cord blood sampling is enough, because both the cord blood sampling and the TSH after 48 hours, the cutoffs, the protocols, everything is same. The only thing we need to remember is we should not do a sampling between the time of birth and 48 hours. Either the cord blood or delay it for at least 48 hours. More than 72 hours will be better, but most of our babies get discharged before that. So either after 48 hours or cord blood should be our sampling. And it is prudent to take a second sampling at 2 to 4 weeks of life for a particular group of babies, which I'm going to explain. And always remember, children with chromosomal disorders, including Down syndrome, Turner, has a higher incidence of congenital hypothyroidism. So we may need a extra screening for them. And 10% of children with congenital hypothyroidism has some of the systemic anomalies. So do a careful physical examination, not an echo or anything, but do a careful physical examination, including auscultation, to find out cardiac CNS abnormalities, and also do a visible birth defect examination. And why second screening is important is some groups of children may have a false negative neonatal screening result or have a high risk of mild congenital hypothyroidism not detected by neonatal screening. So this type of abnormality is more common with those babies who are critically ill, those babies who are born with low birth weight, and also premature babies. So for them, we need a second screen, and either at the time of discharge or by the 10 to 14 days if the baby is discharged earlier. And always remember, in Down syndrome, there is a higher chance of all types of hypothyroidism, not only congenital hypothyroidism, but also acute hypothyroidism, as well as even hyperthyroidism. So we need to screen for thyroid diseases in Down syndrome at the end of neonatal period, then at 6 months, and thereafter every year, so that we don't miss hypothyroidism in a baby with a Down syndrome. So for a Down syndrome baby, the screening doesn't end with the initial newborn screening. It should continue through its life. So this is the filter paper which we are using in our center, and when we are establishing and monitoring a program, make sure that the samples are sent adequately. So when you take the filter paper sample, it should actually fill the circle which is given, and make sure the blood stains the other side of the paper, so that the whole paper is impregnated with blood. Because if the sample is inadequate, the lab may just discard the sample, and the parents as such, as well as the doctor, will think that this baby is screened while the baby has already missed it. So it is very important we take the sample properly and keep it under, dry it properly, and keep it under cold chain and transport to the lab where we do it. So if we don't have such a program, or we don't have a lab with an expertise and infrastructure to do a filter paper analysis, we can very well do a cord blood sample in all babies born. It doesn't need any extra expertise or lab support. It can be done in the routine biochemistry lab, which we have in our own hospitals. And what is the disadvantage of doing a cord blood sample is we could not screen, in such a case, we are not able to screen for other metabolic diseases like galactosemia or congenital adrenal hyperplasia and things like that. where it will take a little more time for the metabolite to accumulate. But if we are just aiming for congenital hypothyroidism, a cord blood sample and filtrate sample are fair enough. And even if we take a venous blood sample while doing a serum bilirubin estimation at 48 hours, that also can be used for testing TSH. And what is the etiology of congenital hypothyroidism? We know mostly it is most of these babies are having an abnormal organogenesis, which is called thyroid dysgenesis. It has a female preponderance, and 50% of them, most of them will be ectopic, and rest can be various degrees of hyperplasia or athyrosis. And usually in athyrosis, if you measure the thyroglobulin, it will be undetectable. Dyshormonogenesis or a lazy gland is another cause for permanent congenital hypothyroidism. It is seen in around 10 to 15% of all children with congenital hypothyroidism. Here, there could be a thyroid enlargement because the gland is properly formed. Anatomically, it is normal. So, when the TSH is high, it acts as a growth factor for the gland. So, it is the goitrous congenital hypothyroidism. There will be some enlargement of the gland. And the defect can be in any of the enzymes which causes the which is involved in the production of thyroxine. And always remember that one type of dyshormonogenesis, there can be associated sensory neural deafness. So we know that universal hearing screen is done for all babies with all babies who are born, but for babies with congenital hypothyroidism, the baby may need an extra test. Once more, if we can do that, will be better. And always remember, dyshormonogenesis is an autosomal recessive condition, and there is a 25% risk for the next sibling also. And there are many reasons why the baby develops a transient neonatal hypothyroidism. It can be due to iodine deficiency in mother. So the baby is born with hypothyroidism, but later it improves. Then there is something called Wolff-Chaikoff effect, means there is a high dose of iodine has reached the baby's bloodstream, either by means of the beta-iodine painting, which happens during the preparation of the delivery, or maybe some iodine-containing drug the mother has taken. So it will stunt the fetal thyroid or the neonatal thyroid, and we get a high TSH. That is one reason. And it could happen with some drugs, other drugs the mother has taken, the wrong technique of sampling as well as analysis. And there is something called asymptomatic hyperthyroidropinemia, where we get only the TSH in the subclinically high range, but T4 is normal. It can occur, it has a higher incidence among Down syndrome babies. And also for preterm babies, there can be a transient isolated hypothyroxinemia. That is the free T4 level will be low, everything else will be normal. For that is also a temporary phenomenon. And of course, the non-thyroidal illness or the sick euthyroid syndrome, where you have a critically ill baby with an abnormal thyroid function. So we have Indian guidelines which came up in 2018, and they are available as PPTs, as PowerPoint presentations in the website of Indian Society for Pediatric and Adolescent Endocrinology. I would like all of you to have a look at it, because they are very useful. It contains case scenarios also, and also gives a guidance to how to establish and how to monitor babies with the congenital hypothyroidism and their screening as well as treatment. So now we will go to the flow chart, which explains how should we go about in babies who are having a positive screen. So a positive screen actually doesn't mean that the baby is having congenital hypothyroidism. Positive screen, both for heel prick or cord blood, it is a value more than 20 milli-international units per liter or micro-international units per ml. So it is any value of more than 20, that baby should be recalled. It doesn't mean the baby has a congenital hyperthyroidism. So explaining the screening result to the parents also is important. We should tell them that the baby has got an abnormal value. The baby needs further evaluation. We need not make them panic. And when they come back, we have to do total T4 or free T4 along with the TSH. In my practice, as Rekapati sir had taught me, I do both the total T4 and free T4 because, as explained, free T4 is important and mandatory because we need to look at the thyroid binding globulin abnormalities. But still, the assay of free T4 available in most parts of our country are not much reliable. So always do a total T4 and free T4 together, so that if both are going in the same direction, we can think that it is a reliable value. Or if both are going in different directions, at least we can repeat it and make sure everything is correct. So when a baby has a positive screen, what we do, if the baby is having a TSH value of between 20 to 40, the baby is recalled in the second week. That is after 7 to 10 days, because there could be some temporary cause which is causing this abnormality. So we give some time for that to settle down so that we can take a decision. But if TSH is 40, more than 40, that means most probably this baby is having congenital hyperthyroidism and we need to start treatment immediately. So we recall them as soon as possible. That is within 72 hours. The test result is available. And whenever a child comes to us for assessment, do a careful physical examination, collect venous sample for T4 and TSH, and then interpret it according to the cutoffs. So always remember only two values. That is, if you are having a T4 value of less than 8 and you are having a value of TSH value of more than 20 or a value of more than 10 beyond 2 weeks, that means the child is having hyperthyroidism, we need to treat. So a value less than 8 T4, always we need to treat. A value of T4 less than 10 with TSH high, we need to treat. And we always have a question sometimes that everything is normal. T4 is normal, free T4 is normal, but TSH is staying high. So after 3 weeks, any baby who is having a normal T4 or free T4, but TSH is more than 10, that baby warrants treatment, because that indicates that there is some problem in the hypothalamo-pituitary thyroid axis. That is why TSH is high. So the gland may be having some minor problem, like a mild degree of dyshomogenesis, or it can be even an ectopic, where because of the high TSH, now the gland is producing enough thyroxine, which may fail later. So any value of TSH more than 10, beyond 3 weeks of life, it warrants initiation of treatment for congenital hyperthyroidism in the baby. So we can always reassess such babies at the age of 3 years. But because by the age of 3 years, the almost 98% of our brain growth is complete, we can stop the thyronome or the thyroxine under close medical supervision and wait for another 4 weeks and repeat the thyroid function test and then decide on continuing the treatment for lifelong or stopping there. So it is very important to monitor the T4, the free T4 and TSH values and make a decision. Actually, the new recommendation which has come from the European Society of Pediatric Endocrinology tells us that a value of TSH more than 6, a TSH more than 6, beyond 2 weeks of life, actually we need to keep the baby under close follow-up and look for the emergence of hyperthyroidism. So that is the individual decision. But for our Indian guidelines, always remember the value of more than 10 beyond 3 weeks. Even if T4 and free T4 are normal, we need to start treatment. And these are the precautions which these are the precautions which we need to take while we are treating congenital hyperthyroidism. The thyroxine is available only as a tablet. No solutions are available. So we need to tablet. And the host mute all the others. And when you are giving the tablet for the initial 6 months, as we all are following the exclusive breastfeeding policy, we need to crush the tablet, mix it with breast milk and give early morning till 6 months of age. And after 6 months, we can use water. And like Raghupati sir says, always ask the mother to give the thyroxine tablet to the baby after the mother brushes the teeth. Only because we need to link it with some routine activity, because this is a medicine which need to be given for a long time. And we all know, we even as doctors, we don't complete a course of antibiotics. So tell them to link it with some routine activity like brushing the teeth and then giving. So once the baby starts brushing teeth, so he can also follow the same pattern. And always remember, we should not give iron, calcium or soya along with thyroxine, because all three can actually decrease the absorption of thyroxine. So if you are giving such medication, it should be given at a different time. And once the tablet is given, we can give the baby the other food and all after half an hour. For the newborn baby, these things may not be possible all the time, but always remember it should be given at the particular time in the day. And repeat T4 and free T4 at 2 weeks, because we are actually focusing on the thyroxine level. If the thyroxine level is normal, then the brain gets protected. So our priority is to make the thyroxine level normal. So do a T4 and free T4 at 2 weeks. Don't do a TSH, because TSH will take more time to get normalized. So TSH we do only at 4 weeks. And there can be a transient elevation of TSH during infancy because of the relative pituitary resistance, because the baby is exposed to very high levels of TSH during its fetal life, so it may stay for some more time. And after that, every 2 months. So initially we start the medication. After 2 weeks, we do a T4 or free T4. And after 4 weeks, we do again a T4, free T4 and TSH. And then further, every 2 months till 6 months of age, every 3 months from 6 months to 3 years of age, and every 3 to 6 months till end of growth, that is till 18 years of age. And always remember, whenever we change the dose, we have to check the adequacy of the dose by doing a T4 and TSH after 4 weeks of changing the dose. So this is mandatory. And never look at the values which are given in the lab results, because most of the values are for the adults. So we need to have a reference of ourselves kept in our own consultation table to refer, because according to the age, the normal values differ. And among the normal values, we need to remember, we need to keep the T4 value in the upper half of normal range for that particular age. We need to maintain the TSH in the normal range. And the recommendation is we need to continue the drug till 3 years of age. There is a recent recommendation that which I will come to later. And regarding the growth, every baby who is having congenital hyperthyroidism should have a growth chart. And actually, I should say all babies, it is not for congenital hypothyroidism only. It should be a universal growth chart. Every baby who is coming to you for immunization should have a growth chart, and plot them carefully and look for any deviations in growth. And development also should be assessed at every visit and should be documented. Head circumference also to be monitored. Hearing and thorough physical examination should be tested during the follow-up. Is imaging important, and how to choose the imaging type? So we have technetium scan, which is otherwise called nuclear scan, and also ultrasound scan. So why imaging is important? Imaging is important because we are going to tell the parents of a newborn baby that we need to give this baby a medicine, even though we know thyroxine is a supplementation, but most of the people will think it is a medicine. So this is going to be given lifelong. So we need to give them some evidence. It will actually help in compliance. And it is good to know what is the reason, and that actually can help us in deciding the dose, as well as we won't be surprised in seeing very high TSH later also. So this is one baby we at our center only. So someone has done an ultrasound, and they have nicely described the lobes of the thyroid gland and all. But for the same baby, when we did a technetium scan, there is no thyroid gland seen at all. So this is a case of agenesis. And in literature also, there is a lot of reports which says that there are incongruent results between doing a technetium and ultrasound, because ultrasound is actually available everywhere. We can do it easily. But the problem is most of the time the subcutaneous tissue in the neck can be misinterpreted as a thyroid gland, and it needs real expertise. So it is an observer dependent test. But for technetium, there won't be any such issues, but it is not available everywhere, and it needs a IV drug to be administered, IV technetium to be given. That's it. So, and this is one of the new recommendations, which says if a child with a no permanent congenital hypothyroidism diagnosis at the time of birth and requires a levothyroxine dose less than 3 microgram per kg per day at the age of 6 months, and at that time the thyroid function is perfectly normal at a dose below 3 microgram per kg, then reevaluation can be done. Maybe at that time, early also. So for example, an 8-month-old baby with a 7.5 kg weight on a dose of 12.5, ultrasound shows normal gland in normal position. We can try stopping earlier, but it is an individualized decision, and we need to keep that particular baby under close follow-up, and we may need to repeat the thyroid function test. Education is the primary thing in treating congenital hypothyroidism, because the drug is very much affordable. Everyone will buy it. There is no problem in getting the drug, but they need to continue it. So we need to educate the parent again and again. In every visit, we need to tell them about brain development, the need of thyroxine for growth, all those things, because adherence to treatment has a real influence on outcome. I don't know what is the experience of others in the forum. I have seen during the COVID, as our follow-ups were limited because most of them were not coming. They all tell that they were taking, but many of the children had some growth faltering during the COVID time. So follow-up and re-education is of utmost importance.
I agree with you, sir. You have 2 minutes time, sir. Thank you.
Okay. So, also education is important for ourselves also, because clinical suspicion of hypothyroidism, despite normal TSH, should prompt further evaluation for primary as well as central congenital hypothyroidism. Why that is important is most of the time we think that once we do a screening at the time of birth, everything is perfect. It is not like that. We have seen babies who have missed the collection of results, and otherwise some had central hypothyroidism. So the TSH was well below 20. We are not asking for low values of TSH to be reported or evaluated, because our program is primarily based on the primary hypothyroidism. So always remember, no screening is perfect. Our clinical examination is also important. Whenever you see a child or a baby who is having any feature of congenital hypothyroidism, go ahead and do the test and make a decision. And I think I will stop here and I will take questions. Amarnath.
Sir, thank you very much, sir. So there are many compliments from the audience. It's a comprehensive, lucid, excellent lecture. So I have few questions to you, sir.
Okay.
Yeah.
Yes.
First one, what is your suggestion from Kerala to the state of Telangana and AP regarding the congenital hypothyroidism screening? We wanted to start. Even ISPE is trying. That is first question.
Okay.
Second question, regarding our TOT, as you know, you and me are the national joint coordinators for training of trainers. So, any updates and any tie-up with our PATS and TCP? Thank you.
So for the first question, I will tell what is being done here. The program actually started in 2013 last, and it was started in government hospitals where there were more than 100 deliveries. And actually we have some public health regional public health laboratories all over the state, like 4 or 5. So from each hospital, it was sent to the nearby regional public health laboratory, where a facility for evaluation of the filter paper sampling was made, training was given. And after that, it is now extended to all the delivery points under the government. And IEP Kerala is doing a program under the leadership of Vijay Kumar sir, to make sure that all private hospitals also follow the same norm, be it a cord blood sampling or a filter paper sampling. No baby will go out of the hospital without a screen for congenital hypothyroidism. We are doing that. And regarding the TOT, actually I think there are a few sessions allotted to the TCB also, so that I will share with Dr. Amarnath as well as the office bearers, endocrinology TOT.
Thank you very much, sir. We are having just last 1 or 2 questions. The question, preterm babies have any cutoffs difference? Can we screen at 2 weeks of age, and should we do only 72 hours, or must both after 72 hours and after 2 weeks in preterm and sick babies?
Okay. Okay. So for preterm babies also, the cutoff is same. There is no separate cutoff. Only thing is due to immaturity of the hypothalamo-pituitary thyroid axis, there can be a delayed rise of TSH. So we need to definitely do a second screening. That is important. And when we are getting some abnormal values, we may need to keep the child under follow-up, and further screening also may be required.
So continuation of the same question they are asking. Usually after 3 weeks we are starting for term babies. For preterm babies, is there any longer cutoff within 6 weeks of more than 20 or 10? Any difference is there?
No. There is no such difference. Any baby who is having a TSH of more than 10, because TSH is a very sensitive what you call test in for congenital hypothyroidism. If you are having a TSH of more than 10 and it is staying like that, we have to start treatment. There is no separate duration of cutoff for preterm babies.
One more last question. Are you screening all congenital hypothyroidism newborn babies, the newborn hearing screen?
Actually, we are doing a hearing screen for all babies. And I would also like to share that under the RBSK program from the central government, we have facilities to screen for all the visible birth defects as well as the metabolic diseases. I think we can use that clause and ask our state to do the same, because funds can be obtained from the center.
Thank you very much, sir. Yes, sir, for taking time and giving your valuable time and inputs and troubleshooting for the Raghupati sir's illness. Thank you very much. Now, I request sir to go for the next session. Over to you, sir.
Thank you.
Hemchand sir.
Hemchand has joined. Okay. So now we are moving to the other side of thyroid abnormalities, that is hyperthyroidism. And I actually I'm personally I'm very fond of talks by Hemchand, because he presents the complex things in a very, very simpler manner. And he's the senior consultant endocrinologist at Mehta Hospital. Has a lot of publications to his credit. And I think he will take all of us to a rare problem, but a very important problem with thyroid abnormality in children, that is hyperthyroidism. Over to Hemchand. Thank you.
Thank you. Thank you very much to the organizers and sir. I think over the next, I'll try to shorten my talk. I think we are running late. But I hope this next 15 minutes or so is very useful for all the practitioners.
Hemchand sir, you have 20 minutes. You take 20
yeah.
minutes. Thank you.
Yeah, I think we are running late. The panel discussion is also there. Anyway, thank you very much. Thank you. Before doing this presentation, I happened to ask the pediatricians working in my institution, what would you do when you encounter a child with clinical features of hyperthyroidism? Uniformly, everybody said only one answer: refer them. I hope this presentation helps pediatricians to conquer this disease and give the children a good evidence-based management. So the focus of this presentation is to just fill up this table. When to suspect hyperthyroidism, at a primary care pediatrician level, what to do, how to approach, and where to be careful and not burn one's own fingers. So the first case is a 10-year-old child who presents with goiter, prominent eyes, sweating, and weight loss. I think the diagnosis is written on the face of the child. What is the diagnosis? No clues about that. There are a lot of pediatric guidelines on management of Graves' disease. The latest one is the 2022 guidelines for the management of pediatric Graves' disease from the European Thyroid Association, which gives very simple, clear answers guiding us how to approach and manage these children. So suspect early any goiter in the presence of tremors, easy fatigability, unexplained fever, weight loss despite good appetite, emotional lability, menstrual abnormalities, a sudden deterioration in handwriting, non-specific anxiety, irritability, sleep disturbances, slightly increased stool frequency, unexplained associated with weight loss, heat intolerance, child previously walking well, now just not able to go into the sunlight, insomnia, previously well sleeping child, now developing a lot of difficulty to get sleep. I think these are some important clinical clues to make a clinician suspect juvenile hyperthyroidism. And quick screening would be to make a meticulous examination of the goiter, see the consistency. It's usually soft in Graves' disease. A bruit may be present. Look at the eye carefully for the presence of exophthalmos, lid lag, and lid retraction. Vital signs, extremely crucial, presence of tachycardia, hypertension, white pulse pressure, and neurological signs like chorea, tremors, and lower limb weakness. These are important meticulous physical examination that one should always perform in a child with suspected hyperthyroidism. So once you make a diagnosis of hyperthyroidism and have a clinical suspicion of Graves' disease based on the presence of eye signs, based on the presence of or hyperdynamic circulation, the basic test one should do is the presence of biochemical confirmation by doing a free T3, free T4 TSH. The previous speakers have very beautifully explained to us the importance of doing free T3 in every child with suspected hyperthyroidism and documenting a suppressed TSH to show the TSH and free T4 are like two ends of the pendulum. Whenever your TSH goes down, your T3, T4 level goes up, as in the case of hyperthyroidism, and vice versa for hypothyroidism. The important test to establish the presence of Graves' disease is anti-TSH receptor antibody, TRAP. It is quite an expensive test done in most of the commercial laboratories. TRAP, TSH receptor antibodies. That is the commercially available test that should be done to establish Graves' disease. This is in contrast for antithyroid peroxidase antibody and antithyroglobulin antibody that one would do in the case of Hashimoto's thyroiditis. TRAB is a very important test that must be done to look for the presence of Graves' disease. Scintigraphy and ultrasound will complement the assessment, but it is not mandatory. So this, if at all you do a scintigraphy, this is you will see the increased uptake, a uniformly increased uptake of the thyroid gland, and the report showing an increased uptake consistent with Graves' disease. So once you establish that this child has clinical evidence of hyperthyroidism, biochemical evidence of hyperthyroidism by doing a thyroid function test, you do a TRAB and you prove that this is Graves' disease, medicate the child. These are the medication guidelines that have been mentioned. Very important safe drugs. Usually carbimazole is used in most of the centers. Now methimazole is also available. In mild cases, start off with the lower limit of the dose. With the presence of significant symptoms, go to the upper limit in severe cases. In children with severe hypermetabolic state and adrenergic activity, a short course of propranolol may be required till the child has significant hyperthyroidism. Once the symptoms abate, the beta blockers can be stopped. The duration of therapy of antithyroid drugs is usually 3 to 6 years. There is no uniform acceptance on the duration of therapy, but the recent 2022 guidelines says it is around 3 to 6 years. Drug therapy remains the primary modality of treatment, preferably once or twice a day in divided doses. Very important that you monitor the thyroid functions frequently initially till the normalization of the biochemical parameters, and slowly you will have to liberalize the monitoring once you attain good biochemical and clinical control. Remember, the control is usually ascertained by free T3 and free T4. TSH may take a while to normalize. Whenever you attain a normal biochemical state, slowly taper the drug to attain the minimal effective dose, the dose that controls hyperthyroidism at one end, at the same time prevents a relapse. The usual maintenance dose is around 5 to 15 milligram per day of carbimazole or methimazole. The lowest dose that attains good biochemical control should be started. The adult strategy of blocking the thyroid function with a stiff dose of antithyroid drugs and adding a good dose of maintenance thyroxine is not recommended in the interest of complications related to drug therapy. Propyl thiouracil is not advised in children. And before starting the drug, always do a complete blood count and a liver function test, because they may be deranged because of the disease per se or associated conditions. A normal CBC and a normal liver function is mandatory before starting these antithyroid drugs. Along with that, always periodically monitor the TRAB towards the end of the therapy when you decide to taper or withdraw the drug. And it should be done over a prolonged period of around 3 to 6 years. So coming back to this golden power slide. So when does a pediatrician suspect hyperthyroidism due to Graves' disease? Significant clinical features of hyperthyroidism associated with eye signs and goiter. What test would she do? Along with thyroid profile, an anti-TSH receptor antibody. Early initiation of antithyroid drugs, carbimazole and methimazole, may require a short course of beta blockers. Always monitor complete blood count and liver function test. The second case. This is a 10-year-old girl with goiter. On examination, found to have tachycardia and wide pulse pressure. But if you see this goiter, it is a firm, irregular goiter. An important clue, there are no eye signs. Whenever you have the consistency of goiter to be irregular and firm, and whenever you don't have eye signs, be careful. It may be a transient phase of hyperthyroidism in a child with Hashimoto's thyroiditis. This is classically described as Hashitoxicosis. This is published data on Hashimoto's thyroiditis from various Indian centers, including our center, which is published in 2016. You will see that across the centers, there is a small percentage of children, around 2.5 to 3%, in some centers around 10% of the children, a small subset of children with Hashimoto's thyroiditis who may have release of preformed hormones and have hyperthyroidism. They need not be aggressively treated. They need not receive anti-thyroid drugs. It's very important that pediatricians recognize who is Hashitoxic and who has Graves' disease. As said previously, the important two clues is the consistency of the goiter as well as the absence of eye signs. This is data from the Western world who has observed and followed up children with Hashimoto's Hashitoxicosis who had negative TRAP. Your absence of anti-TSH receptor antibodies helps you make a diagnosis of Hashimoto's Hashitoxicosis. And the duration of hyperthyroidism was around 6 months to 1 year. So this is described to be 8.8 in a series of children from Italy and around 3 to 8 months in another study. So the duration of these children and the requirement of monitoring and follow-up is for a short while, for just a few months. And usually it resolves. So the mechanism is release of preformed hormones. The clinical clue is the consistency of goiter, absence of eye signs, and absence of antibody. A scintigraphy may be very useful in this setting to identify a reduced uptake. If you see Graves' disease, the uptake is increased. If you see Hashitoxicosis, the uptake will be reduced. How to manage? It is usually self-limiting. A small course of beta blockers may be required if the child is severely symptomatic. Aggressive forms of therapy like radioactive iodine or surgery may not be required. Coming back to the golden table, Hashitoxicosis is suspected when there is a goiter which is firm, when the eye signs are absent. This is confirmed by the absence of TRAB as well as scintigraphy, which shows a reduced uptake. The approach would be mainly clinical follow-up. A short course of beta blockers may be required. Never start these children on anti-thyroid drugs initially itself. A high index of suspicion is needed to make this diagnosis. Coming to the third scenario and a common scenario with the epidemic of adult hypothyroidism, which clinicians and pediatricians are going to encounter. A 3-year-old child presenting to the emergency room with an injection of unknown quantity of thyroxine tablets. What are the basic things to remember? What are the red flag signs a pediatrician should look for? And how should a pediatrician approach this child? A meticulous history and assessment of the strength, the number of tablets, and the probable dose consumed. Watch for like a quick assessment of features of hyperthyroidism. And remember, because of the long half-life of thyroxine, which is 7 days, the child may present with clinical and biochemical evidence of hyperthyroidism delayed. So the testing is best deferred to around day 3 to day 5, and symptoms can appear as late as 14 days. So just because a child is well in your ER, despite consuming an unknown quantity of thyroxine, don't discharge the child. Keep the child on OP follow-up, meticulously follow up the child by either a direct or a telephonic conversation, and watch for signs of hyperthyroidism. It has been proven that there is no correlation between the dose, the severity, the levels, and the onset of symptoms. It is highly variable based on multiple physiological variants. If the child is significantly symptomatic, a very significant elevation of free T3 and free T4, or the consumption is very significant, the child may need to be admitted. But biochemical testing is not to guide you on the drugs, but to guide you on proof of ingestion. Remember, children have an option of converting T4 to RT3 as well, and they may not develop very severe symptoms in the initial stage. If the child is asymptomatic, observe. If the child has mild symptoms, a short course of beta blockers. In the presence of severe symptoms, child may need to be admitted and treated with steroids and cholestyramine. In very, very symptomatic children, they may require a PICU care. Coming back to the golden table, a pediatrician should suspect hyperthyroidism because of drug ingestion when he presents to the emergency room with consumption of unknown quantity of thyroxine tablets. The test to do would be delayed testing of free T3, free T4, and a TSH. Clinical follow-up of up to 14 days, judicious beta blockers is what is recommended. Be careful, they can have delayed appearance. Don't discharge the child just because the child doesn't have immediate symptoms. A rare case, a 10-day-old baby presenting to you with goiter, history of Graves' disease in the mother who is on treatment with neomercazole. This child has features of hyperthyroidism and a diagnosis of neonatal hyperthyroidism is arrived at. Remember, a baby born to a mother who has Graves' disease is a volcano, it's a dormant volcano. The child may remain euthyroid, child may develop transient hypothyroidism, child may develop permanent hypothyroidism, and child may develop neonatal hyperthyroidism as well. So be very careful with these babies. Keep the child, all neonatologists keep these babies on close follow-up. Transplacental passage of anti-TSH receptor stimulating antibodies can be a cause for hyperthyroidism in the child. So initial measurement of TRAB should be done as soon as possible. I repeat, initial measurement of TRAB should be done in babies with hyperthyroidism among the mothers as soon as possible. Testing for thyroid profile, a free T3, free T4, and a TSH can be done a little bit delayed for waiting for the evolution of symptoms by around day 3 to day 5, and a repeat testing by about 2 weeks of life. I repeat, testing these babies, irrespective of the initial screening report, should be done by a venous test by around day 5 of life and 2 weeks of life as well. This is one report of a child with neonatal hyperthyroidism that we have reported. Remember, the approach is very simple. If the TRAB is negative in the baby, follow up the baby. If the TRAB is positive with just biochemical symptoms, OP treatment. If the TRAB is positive with biochemical and clinical evidence, admission. And if you have feigns of decompensation, it would be an NICU admission. A traffic light approach. Just biochemical, OP treatment. Clinical features onset, inpatient, and severe symptoms would be admission in the intensive care. The main drug one should use is antithyroid drugs, methimazole in this recommended dose in 1 to 2 divided doses. With sympathetic hyperactivity, they may require propranolol. In sick children, sick neonates, you may require a short course of prednisolone as well. Coming back to the golden table, when to suspect hyperthyroidism? A neonate born to a mother who has Graves' disease and positive TRAB. At day 3 to 5, as well as a 2-week free T3, free T4, TSH is mandatory. Close monitoring and biochemical testing is pivotal. Short duration of therapy, usually around 6 weeks, as long as a TRAB which comes from the maternal circulation is there in the baby's body, has to be followed up. And the drug can be withdrawn quickly. This case was discussed previously. A sick child admitted for sepsis, septic shock. Despite all appropriate measures, there is persistent tachycardia and persistent wide pulse pressure and fever and a hypermetabolic state. A shrewd clinician picks up a goiter, subtle eye signs, and a biochemical test is done, and the child is confirmed to have hyperthyroidism. A very rare scenario, but a pediatrician should be sensitized. A thyroid storm, a hyperthyroid emergency can be a presentation in the PICU. It is a hypermetabolic state resulting from increased levels of thyroid hormones in the blood, usually presents with fever, tachycardia, and high output cardiac failure. Rare complications including acute kidney, liver injury, coagulopathy can also occur. Valuable clues is looking for persistent tachycardia, eye signs, wide pulse pressure, previous history of Graves' disease in the presence of stressors. This is a scoring system validated in adults, can also be useful in specific clinical situations. Remember, thyrotoxic periodic paralysis where high free T3, free T4, TSH can activate the sodium potassium ATPase in the presence of stress or high carbohydrate load and presents with hypokalemia and muscle weakness. There is a pushing of potassium into the into the intracellular component. They present with lower limb weakness involving the proximal muscles and may present like an acute flaccid paralysis. And the culprit may be hyperthyroidism. These children may require thyroxine supplementation along with KCl replacement as well. This is the replacement of children with thyroid storm, preferably done in a PICU setting with a multidisciplinary team approach. The key drugs would be steroids, lugolcidine, and beta blockers, along with antithyroid drugs. So coming back to the table, thyroid storm, sick child with a goiter, persistent fever, tachycardia. A thyroid profile should be done a rational approach using antithyroid drugs and steroids. Potassium supplementation, never forget, in the presence of acute muscle weakness. This is the last case, a 12-year-old child with goiter, very, very prominent, as you can see, obvious nodularity, previous irradiations, and a scintigraphy done shows at the sign of a hot nodule, a solitary thyroid nodule, which is hyperfunctioning. This child should be referred to a surgeon. So to rule out malignancy. So hyperthyroidism with a nodular thyroid disorder, the first test to do would be a scintigraphy, an early surgical referral, never miss a malignancy. I hope this 15 to 20 minutes of presentation has helped the pediatrician change the answer from referral to ascertaining the cause, severity, rational management based on the cause. Just to sum up, when should a pediatrician suspect hyperthyroidism? Just 1 minute, I'm almost done. Graves in the presence of hyperthyroidism, eye signs, and tachycardia. Acetoxicosis in the presence of goiter, hyperthyroidism without eye signs. Consumption of unknown quantity of thyroxine tablets. Newborns born to mother who have hyperthyroidism, Graves' disease. A sick child with tachycardia, wide pulse pressure, and a goiter. And a hyperthyroidism with a nodular thyroid disorder. The test would be to do either TRAP or scintigraphy. Is very important to help you elucidate whether it is Graves or acetoxicosis, or whether it is a hyperthyroid ingestion, or whether it is transplacental passage of maternal antibodies. The approach would be in Graves, start them on methimazole or carbimazole. Please check the CBC and liver function test. If it is acetoxicosis, clinical follow-up may be beta blockers. A scan is mandatory. Unknown quantity of thyroxine tablets, judicious beta blockers. Delayed appearance should always be kept in mind by the clinician so that the signs are not missed. Neonates born to mothers with Graves' disease, a delayed testing of PT3, PT4, TSH, or early testing of TRAB to ascertain the risk. Thyroid storms, always a thyroid profile, antithyroid drugs. Never forget to supplement potassium in acute muscle weakness. And a nodular thyroid disease with hyperthyroidism, early surgical referral to not miss a malignancy. I think this would be a simple approach to hyperthyroidism in day-to-day office practice. Thank you very much.
Thank you, Hemchand. I think now everyone will agree with me that a complex topic has been made simple. And we do see cases of hyperthyroidism in our pediatric practice. And we should be able to handle it well. So that is important. And one question, Hemchand, regarding this side effect profile of these antithyroid drugs are really very important. So how can a pediatrician, like before starting, so what to do like that? Any advice?
See, I think as mentioned in the PowerPoint, basically complete blood count as well as a liver function test is mandatory because that may be influenced by the disease per se. And periodic monitoring of these parameters on follow-up is very important. And when you find the absolute neutrophil count inching downwards, or when you find the liver function test rising, I think it is an indication for us to go in for alternative forms of therapy like radioactive iodine or surgical management. Our hematologist feels an absolute neutrophil count below 1,500. Be careful, and below 1,000, the drugs should be stopped, or a reduction in the dosage of the drugs with a parallel increase in the beta blocker dosage, so that you temporarily tide over the crisis is what one should keep in mind. And other thing is, you should also remember Graves is an autoimmune problem. They may have associated autoimmune problems, and autoimmune problem which affects the hematological system should also be kept in mind when you have a derangement in the complete blood counts. And that is especially noted in children with trisomy 21. So I think these are the things that one should, pediatrician should keep in mind while treating hyperthyroidism.
Thank you. Thank you.
Thank you, sir. Thank you.
So there is a request to show the last slide once more. I think to take a
screenshot.
Thank you, Dr. Hemchand.
Thank you. Yeah, thank you very much, Dr. Hemchand sir. He's a co-author for the textbook of pediatric endocrinology and also editor for our Cape News. I thank Riyad sir for troubleshooting. We once again remember Raghupati sir. If possible, he can join. He is listening from the bed. We are grateful to you, sir. This ends the first session on thyroid disorders. Any questions can be asked in the chat box, and myself, Hemchand sir and Riyad sir will be answering. Now we are going to the second session. There's interesting case scenarios other than the thyroid. Now I request Hemchand sir and Linita Reddy madam to moderate the session. As first session is by Linita Reddy, now I request Hemchand sir to take over the moderation of the second half of the session. That is interesting case scenarios in pediatric endocrinology. It will be a short session, 8 minutes presentation, 2-minute summary, take home messages to the pediatricians, and last 5 minutes expert comments and question answer session. Over to you, sir. Hemchand sir. Once again,
thank you very much.
Thank
you very much. Thank you. I think we have a very interesting panel discussion that is lined up on very simple aspects of common problems seen by pediatricians. Over to the first panelist to start with the case presentation.
Yeah, Dr. Linita Reddy, madam, is a senior consultant from Rainbow Hospital. Here, just a second. We request host to unmute Linita, Dr. Linita Reddy, please.
Yeah.
Thank you. So, madam is a senior consultant and a leading pediatric endocrinologist from Rainbow Hospital, has done maximum research work, and upcoming days, within 2 weeks, they are having the adolescent endocrinology with the gynecology team. She is my teacher, colleague, and guide, guiding the Pediatric Endocrinology Forum of Telangana and IAP Twin Cities. Over to you, madam.
Can you see my screen?
Yes, yes. We are able to see.
Yes, ma'am.
So good morning, everyone. The start, just to thank the Iaptcb for giving us the opportunity today to talk about an endocrinology symposium. I'm just going to start off with 2 cases, but there are a couple more cases by my colleagues, so I'll try to finish as soon as possible. So I'm going to, as I said, I'm going to talk about 2 cases and a little bit of information about just highlighting the points that need to be remembered about these particular cases, and then open for questions and discussion. So the first case is about a 4-year-old girl who presented with concerns of slow height velocity. Parents had brought her into clinic because of the concerns. And one of the main reasons was she had started school and parents had noted that she was one of the shortest in the class. She was born at around 38 weeks, was around 1.9 kilos, breastfed, appetite was good, development was normal. There were no hospital admissions or any evidence suggesting that there is an underlying nutritional or chronic illness. So we plot. Fortunately, this child had quite a lot of measurements done. Some of the measurements were actually done by parents and some by their pediatrician. And we were able to plot it on the growth chart. And as you can see, both the height and the weight were below the first centile at the time of birth. And as time passed, the weight started to improve. And by the time the child was around 2 years, it was close to the 25th percentile and now just below the 50th percentile. But when you look at the height, well, the height hasn't improved. It just continued to follow below the centile line. So based on the history, the diagnosis which we're suspecting here is small for gestational age, where this child has shown catch-up growth of weight, but failed to show catch-up in height. So this is just based on the history on the growth chart. We still need to investigate to make sure we're not missing out anything. So an RP1 was normal, thyroid profile was normal, IGF-1 was 146, bone age is 3 years, 10 months. And being a girl, we always do a karyotype and it was 46XX. Discussion was done with the family that this is an SGA who didn't show catch-up growth in height. So the consideration of growth hormone therapy was made. Having a little problem with the slides. And then we started on growth hormone injections. So if you can look at this chart where we started growth hormones are between 4 to 4.5 years of age, you can notice that there is an improvement in the growth chart already in the height velocity. Just I'm having a little problem with the slideshow, Amarnath.
We are able to see, you are unable to.
I'm not able to move forward.
You can try again, once again, share.
Let's see.
Or you want me to?
It's really frozen here.
No, you stop sharing and once again you share. You try.
Yeah, okay. Can you see now?
No, not it. Yes. Now we are able. Yes. Now we are able to see.
I hope that it's working.
Yeah, working. Go ahead.
Okay. So as you can see, when we continued growth hormone therapy, the child's height velocity improved. And by the time the child reached around 8 years, had reached the 25th centile and continued on that centile line. So we decided to stop growth hormone treatment and followed the child up for further 2 years, and the child continued to grow along the centile line. Now, it's very important that we remember about SJ babies because a lot more babies are being who are born are underweight or being born early, and they're all surviving and doing extremely well. And they tend to follow up with their neonatologist for the first 1 year, and then they drift away and start getting followed up by their local pediatricians or their family doctors. And somewhere the birth weight tends to get missed out. So it's very important that we remember about the birth weight. So SGA is defined when the birth weight or length of both is less than the 2 standard deviations below for gestational age and gender. 20% of these babies don't show catch-up growth, and the length catch-up growth tends to be affected more than the weight, and the catch-up is extremely slow. On top of it, these children are at risk of early puberty, and in the last 2 years, I think we've seen a lot of girls presenting with early signs of puberty. So it's very important that we address it and make sure that the final height isn't compromised. So criteria to start growth hormone treatment in SJ babies is birth weight or length more than 2 standard deviation below the mean for gestational age or gender. Height is less than 2.5 standard deviation of the mean. Current height is more than 1 standard deviation below mid-parental height, and failure to catch up by 4 years of age. A lot of US-based studies will say 2 years, but we tend to wait until 4 years because a lot of our babies tend to catch up between 2 to 4 years of age. So second case is about a child, again, who was referred at close to 2 years because of slow height velocity. And the investigated by the pediatrician who noticed some changes and had started doing some investigations because there were some clinical features, and those features were addressed. Yeah, the birth weight was around 2.9 kilos and was referred just after 2 years. And otherwise, again, no significant history suggestive otherwise, developmentally normal. Again, so slight bowing of the legs was noted. Some frontal bossing was also noted. So the pediatrician had investigated. Calcium at that time was 8.2, phosphorus was 2.2, vitamin D was 12, IGF-1 was 48, TFTs were normal. So the pediatrician decided to treat for vitamin D deficiency, which was visible, and had treated with supplementation for 10 weeks along with oral calcium supplements, and had asked them to come back to see whether there was an improvement. The child hadn't shown a lot of improvement. So the repeat investigations were done, and the calcium was better, phosphorus was still low, vitamin D was normal, thyroid profiles were normal, IGF-1 was 52. They did a bone age X-ray, which showed a bone age of 1 year, 3 months, but also showed coarse trabeculation. So based on this, is this growth hormone deficiency or is this rickets? Because initially the child was referred to me because of possible growth hormone deficiency because of the IGF-1 being low. So I had to further repeat some investigations. So we repeated it, and calcium was 8.8, phosphorus 2.8. As you can see, vitamin D was normal, ALP was elevated, PTH was slightly on the higher side, but not significantly high. Urine showed increased phosphorus in the urine of 100 mg per DL, and TRP was low. That is the fractional excretion of reabsorption of phosphorus. So based on this investigations reports and the diagnosis, a possible diagnosis of hyperphosphatemic rickets was made. Genetic studies done which showed the FEX mutation and confirmed it. There was no family history. And this is something we all have to remember is, especially when there is no family history, there might be a delayed diagnosis. These children don't present to us with body aches or bone pains. There's usually disproportionate short stature, progressive bowing of legs from around the time they start to weight bear, dental manifestation like abscesses, abnormal mineralization. Biochemically, the diagnosis made on low phosphate, raised ALP, calcium and PTH being normal, increased urinary excretion of phosphate, high FGF23, and a low active vitamin D. So how do we treat it? Treatment is oral phosphate and active vitamin D, but you need to be very careful about the monitoring, because if you don't monitor these children properly, you will land up with complications. If you undertreat them, then the rickets is going to get worse. If you overtreat and try to keep the phosphate in the normal range or high normal, it can trigger PTH production, which can result in secondary and tertiary hyperparathyroidism. That has to be controlled with active vitamin D. ALP is a good marker to see whether rickets is healing. So usual follow-up is with ALP, PTH, and a phosphate level. And you adjust the doses to keep all the three, at least PTH and ALP in the normal range, and a slightly one with the phosphate. So what do? We need to monitor our height by monitoring, plotting, and reviewing them regularly. The growth monitoring is a good tool. You need to use it to diagnose children with nutritional deficiency. Sorry about this. I think the slides are on a timer and they're moving forward before I'm completing it. So basically, just to highlight that short stature is, we all know the definition. I think it's been repeated multiple times. So if you have a child who is short, you need to have a structured approach as to how you take a history and diagnose them and plot them and measure them. Now, these are the two new growth charts which are available. As you can see, you have two extra information beside it from which you can calculate the mid-parental height. This allows you to do it without even using a calculator. All you require is mother and father's height. This again is just to highlight that it is important that we don't always think about endocrine causes when it comes to short stature. Normal variant is still a significant part of it. malnutrition, chronic disease, IUGR, rickets also constitute it. Under endocrine causes, hypothyroidism, which we've heard a lot about, which can compromise height, is one of the significant causes for short stature in children. There's one more slide. So just to remember, the main points to remember here is that we measure the child, plot the child, and monitor the child regularly. It's important that we document the birth.
Vinita, one slide you have to go back.
No, that's the same thing I'm saying. It's just
Thank
gone
you.
on a timer.
Okay.
The most important thing, as I said, is measure, plot, and monitor. Birth weight is important to document. As I mentioned earlier, a lot of the babies follow up with the neonatologist for the first 1.5 years, and then they tend to go back to their local family pediatricians. So it's very important that we make a note of it, because that tends to get missed out. The third thing is that we take a detailed history, measure the parents, plot the parents' height, calculate the mid-parental height, detailed physical examination, especially pubertal assessment. Now that, especially in girls, we're seeing puberty starting much earlier, we need to review, examine them, and identify whether puberty has started for these children. Simple investigations, just do an X-ray. Again, doing the X-ray is easy. Actually, calculating the bone age is a tricky one, but there are a lot of apps available which you can use to calculate your bone age. Don't forget to do a karyotype in any girl who presents with short stature. Thank you. And really apologize regarding the slides, because I think they went on to a timer and they were moving faster than I was talking.
Thank you very much, ma'am.
So,
very beautiful 2 cases illustrated by madam. Very apt for the situation. Regarding SGA, I think as pediatricians and neonatologists, very important that birth weight and length be measured properly at birth, documented on their records, and plotted on the appropriate charts. In this case, the Intergrowth 21 chart, so that when they come for follow-up, a proper diagnosis of SGA can be made and the doxology can be interpreted. The second thing is the extended growth charts are very useful for neonatologists who practice follow-up of babies who are born SGA, so that you can pick up the babies who had the minus 2.5 ST deviation deceleration early. And third, and the most important thing, is the IAP 2022 guidelines on vitamin D are available, that helps pediatricians to pick up children with non-nutritional rickets early, as well as prevent toxicity while treating children with vitamin D deficiency rickets. It's available in the IP website, should be downloaded and should be practiced. The second case will be presented by Dr. Amarnath. He'll be presenting an interesting case of obesity and metabolic syndrome.
Thank you very much. So I will be very short. You know everything about obesity. So within 5 minutes we'll be completing the session. Most of the things you know. Just will touch on the what are the newer things in. Yeah. So this tracking is very important in obesity. So here you are able to see. So mother is thin, but both the children, siblings, are very obese. Here you are able to see both are short and obese, and here the same kids. So what is the difference? Please answer in the chat box. So here it is a familial obesity, or the exogenous obesity, or the constitutional obesity. Here both the children are studying in the hostel, not doing proper exercise, eating junk food. Mother is thin, but they are becoming obese. So before I start, I wanted to tell that because of this COVID era, we all are becoming obese. Please be aware of that. Please check your BMI once in a month, especially on first Sunday or something, and reduce our weight. It's the most important take-home message. Second thing, before I start, most of the people thinking obesity as a healthy. My child is very healthy, very healthy. Healthy means obese. Huh? These days, mother wants all the children to be obese and chubby. So that's not correct. That we should know. These are the some more obese children. Obesity with short stature. Case of hypothyroidism. So the case of obesity with type 2 diabetes. Patient came from Kolkata, referred by Asian Institute of Gastroenterology. Again, referred for the gynecomastia, not for the obesity. More than 50% of the times, especially like cities in Hyderabad, so it is for the micropenis, Muslim patients they are referred. They are thinking it as micropenis, but it's a buried penis, we should know. And some more patient for the blackish discoloration over the neck. So if we notice this, so more than 50% patients are hump over the neck, that is deposition of the fat. Some patients for the obstructive sleep apnea, like that. So again, Cushing features, the syndromic obesity, acromegalia, this is Prader-Willi syndrome. So just overweight child because of nephrotic syndrome, steroid-induced obesity. This you are able to see stretched penile length is not done. So buried penis because of the fat. So always stretch the penis and check for the penile length. So here you are able to see the acanthosis nigricans. The infantile obesity, very common. 30 to 80% of children, after when they start walking, running, it will reduce after 1 year of age, even creeping and crawling. So obesity with the marker, short third and fourth metacarpal, syndromic, especially Turner syndrome and pseudohypoparathyroidism. So definition of obesity, we all know, the adult 23 to 27 is overweight, more than 27 is the obesity. But in children, it is 50th centile C for the height. If height is more than 50th centile for the midparental height, it is exogenous. So these are the charts, IAP charts, boys and girls. So use the application, very beautiful application, where you are able to see, for example, overweight and obese. So here you can get chronological age, it is like that. So IAP BMI growth chart, the various percentiles we are able to see. So if you see here, example, BMI is low. Here you are able to see BMI is just 16, but you are able to see overweight. Here BMI is 19. It's also overweight. So don't think that only measuring BMI is enough. So please chart on the BMI chart, and we'll go to the newer BMI chart. Just if you use the scale, you will be able to see the whether overweight or obesity is there or not. So again here same thing, measure the midparental height. So if midparental height, we can rule out the other causes like familial short stature and skeletal dysplasia also. So less than 5 years, use the weight for the height charts below 5 years. So do the growth velocity chart, very important. So normally 5 centimeters per year everybody should go. So if it is less than that, think of either syndromic obesity or endogenous or endocrine obesity. So newer thing, waist circumference more than the wrist circumference and waist circumference. These are the newer things. Waist circumference more than 75th centile defined as obesity. So adolescent girls, they are referred for the acanthosis nigricans and the hirsutism. So it's a case of Hare-Ann syndrome. So again, prehypertensive metabolic syndrome. HbA1c is borderline from 5.7 to 6.5. We call pre-diabetes. Again the same case. History, sleep hygiene, very important. Nowadays we are awake till 1 o'clock, 2 o'clock. That's not good for health. Diet, screen time, lifestyle, time allotted daily for physical activity. Please note this, we are decreasing after this COVID era. Yoga, Surya Namaskar, karate, tennis, football, whatever they want. The best exercise in the world are the jogging, swimming, and brisk running. Anthropometry, take all the BP, look for hypertension, look for genetic cause dysmorphism, Cushingoid facies, hyperpigmented striae, like that. Then short force of metacarpal. Look for buried penis, very, very important, commonly missed. So coming to the investigation, bone age will tell us to differentiate between endocrine obesity or exogenous obesity. There is no need to do fasting insulin normally. So 25-hydroxyvitamin D also routinely not done, because though it is present in the liver, absent in the blood. So universally we just give the twice RDA of the vitamin D, it is deficient. So coming to the OGTT, 1.75 grams per kg glucose for the pre-diabetes children or obese children we need to do. HbA1c more than 5.7 is pre-diabetes. So these are the various complications, we are not going into that. Just metabolic syndrome, what is the, from 6 to 10 years, 10 to 16 years, more than 16 years. Adiposity waist circumference more than 90th centile, 90 centimeter in men and 80 centimeter in women. So dyslipidemia, so triglyceride levels and HDL levels we have to do, and hypertension. So adiposity plus any two of these four is considered as metabolic syndrome. So AAP guidelines shows when to refer to pediatric endocrinologist. Whenever the random blood glucose more than 200, FBS more than 126, HbA1c more than 6.5, alone is not significant. So TSH more than 10, yes, you have to refer to endocrinologist. Elevated TSH and positive thyroid antibodies also. Then some other conditions like they have commonly NASH, that is non-alcoholic steatohepatitis, or just dyslipidemia. It can be treated by just nutritionist and the pediatrician. So exogenous is more commonly we have seen. Then endogenous is 10%. So just concentrate on all these things. Sometimes they may require CPAP. The extreme obesity, they require CPAP because obstructive sleep apnea is there. So you know the light system, green, red and yellow. So most of the times what we are eating is chips, fried food, there is Lay's, Kurkure, chocolate, biscuit, ice cream, Bonda, Bhaji and Coca-Cola. All these come under red light. Don't use that. Use always green light, vegetables, whole grain, whole pulses, low fat milk, curd, paneer, lean meat and all. We don't like this. This is a problem. Again, snacks comes under the yellow. Moderate physical activity, all these things should be done. Pharmacological therapy, Orlistat, that's 12 to 16 years used. So it inhibits the gastrointestinal lipases. So it reduces BMI by 0.7 to 1.7. So it can cause vitamin E and D deficiency. So 75% stop after 3 months. So most commonly metformin is used when associated with NASH and diabetes or pre-diabetes. The dose start with the 500 mg per kg, 500 mg per dose, 1 or 2 times, maximum up to 2 grams. Useful in PCOD and fatty liver. So these are the examples. Bariatric surgery is required when it is BMI more than 120%. After that is also 18 years of age. So we'll go for the diabetes. So whenever the HbA1c more than 8.5 with ketosis, without ketoacidosis. So less than 8.5, no acidosis, just start with the metformin. This is the ADA guidelines. More than 8.5 requires the basal insulin. Either you can use NPH insulin or Lantus or Tresiba, that is decludec insulin. Ketoacidosis requires the IV insulin. So do antibody test, that is mainly we do GAD65 antibody. So positive, think of type 2 diabetes or type 1.5 or type 1 diabetes. Sometimes obese children have type 1 diabetes. So 2 to 6 weeks has to be continued, then slowly tapered off up to 0.5 units per kg per day. Then look for HbA1c. Then usually within 3 to 6 months it will come. So obesity care center, so pediatrician, secondary is the endocrinologist, tertiary, all the people. So management, it involves child, family, school, community, and all the people. So relax your mind and laugh in between. Do some meditation. Compulsory dish should be like this. Play a lot, think less, do more. So ideal diary maintenance. So how much servings of fruits and vegetables we are taking? Minimum it should be 3 to 5 times. Screen time maximum 1 hour. In holidays it can be up to 2 hours based on the, especially when we are going to sleep and when we are eating, you should not have a screen time. So you should monitor like this. So in a nutshell, every child has a right of tracking as optimal growth. Every pediatrician must start using BMI and growth chart. Self change is must for doctors and teachers. See, we are teachers and doctors. We ourselves should change first. Fitness and absence of overweight, obesity must be criteria for selection, promotion for students and adults in their schools and jobs. It's a very, very important. Screen time, free days, zones, interpersonal relation should be developed with yoga and laughing and meditation clubs. ISPA and IAP should start maintaining overweight and obesity registry. Eat half, walk double, laugh 4 times. This and love infinite. This is Jen Proverb. So this topic was done by Dr. Anurag. So this is subclinical hypothyroidism because of increased leptin. You know, increased leptin causing the increased TSH but normal free T4 and increased T3. Already done. So metabolic syndrome we have done. Post-COVID steroid treatment is also causing. Please be aware of that. So what are the newer things in the growth chart? From 8 to 18 years, there is a newer chart. Just use the scale. You can chart on this. Without doing BMI, you can weight and height. It's a very easy technique. And in your mobile, there is a dashboard screen time. There is another application is there. Be aware of that. You can see how much time I have seen. Like 4 hours 19 minutes. We have seen the screen time like that. You can adjust. Digital well-being application. So play and laugh therapy is very important. Don't mind the mind. We are very serious. Gujarat government already started to ban the junk food in schools. So previously it was different, but now eating healthy eating plate method. So colorful fruits, vegetables, grains and proteins. So newer advancement, wrist circumference, body fat percentage and tricep thickness with calipers. So start taking weight and height BMI of both parents and parents. So we are neglecting the parents. So do for parents also. Take weight velocity and height velocity. Normally we are taking always weight. We are forgetting the height. So take both height and weight velocity. How much is increasing and decreasing? Height will not decrease, but weight will be reduced. You can aim for 1 to 3 kg reduction every month. Use IAP growth chart application and newer BMI charts. Use 50th centile height for the family on height for age chart to classify exogenous versus endogenous obesity. Thank you very much. Any other questions we'll take. Sorry, I went little fast because of lack of time.
Thank you very much. You covered the entire obesity very beautifully in a nutshell over the 10 minutes. There are no questions. Just to add, IAP has come up with very beautiful parental guidelines on obesity as well as standard treatment guidelines, which are available on the website. All pediatricians should use them in their day-to-day practice as well as follow them and recommend to their patients when they see obese children. Thank you very much. The third case will be presented by Dr. Srisha Kuthma. She is a pediatric endocrinologist at Rainbow Hospital.
Thank you, Dr. Hemchand. Thank you for the organizers. Can you hear me and see my screen?
Yes, yes.
So thank you for the organizers, Iaptcb, Dr. Bhaskar and Dr. RSV for giving me to share the platform with my amazing senior colleagues. So we're going to just go through very briefly regarding a child who presented with circulatory shock to the emergency room. So we had a 7.5-year-old boy who presented to the emergency room with very short history, vomiting and loose stools over the last 2 days. My child started feeling lethargic and a little bit too sleepy since morning, just the day before the presentation. So when you went and examined the child on the emergency bed, the child is febrile, he's conscious and coherent. He's able to talk, though he feels a bit sleepy and drowsy. But his pulse rate was high, he's having hypotension, and his peripheries are cool with weak pulses. Interestingly, there are no other signs of dehydration. And his systemic examination was quite unremarkable. And he looked like a normal child. He doesn't have any obvious, did not have any obvious dysmorphism. His development was normal. He was of average intelligence. His weight and height, the growth parameters looked pretty much okay. They're falling within 1 standard deviations of mid-parental height. So because the child is having decompensated shock, of course, the doctor in the emergency went ahead with fluid boluses, inotropes, and IV antibiotics, and the child was admitted to the intensive care. So the initial workup was like this. Sodium was low at 121 and potassium was 7.6. Child also had metabolic acidosis. And because electrolytes were low, urine electrolytes were sent with a team. And you can see that the urine sodium was also high, and as does the urine osmolality, even in the presence of low serum osmolality and low serum sodium. And his blood glucose was kind of borderline at 72 milligrams per deciliter. The rest of the investigations were quite unremarkable. CBP, liver functions, creatinine, everything was within normal limits. Not much of an increase in inflammatory markers as well. CRP was also normal. So what are we dealing with here? So we are having a very clear hyponatremia with a renal loss of sodium. We're having hyperkalemia, hypotension, requiring 2 to 3 inotropes, and metabolic acidosis and borderline hypoglycemia. So all this kind of dyselectrolytemia and this kind of fits into adrenal insufficiency. So what we did was we drew samples for all the diagnostic workup and went ahead and gave the IV hydrocortisone stress dosing without waiting for the reports. So the next day when the reports came, we had a serum cortisol of extremely low serum cortisol. This is extremely relevant in the presence of such a severe hypotension. You would expect high serum cortisol. So this indicates glucocorticoid deficiency. And we also had quite a bit elevated plasma renin activity and a low aldosterone, which indicates a mineralocorticoid deficiency. So what we are dealing with is definitely adrenal insufficiency. And this looks like it's a primary adrenal insufficiency because ACTH was quite elevated as well. So when what was not noticed in the emergency room was noticed now when we went back to the child and tried to examine the child. You can notice the clear-cut hyperpigmentation of his lips and the hyperpigmentation of his palmar creases. And when the history was re-elicited, the parents could actually tell that in the last 2 to 3 months, child had salt craving, was showing a lot of preference for saltine crackers and chips and such sort of stuff. So how do these cases of primary adrenal insufficiency present? Most of these cases are, they often present with very, very delayed diagnosis because the symptoms are so non-specific and very, very slow onset. They often have very, very general symptoms like fatigue, anorexia, weight loss, and sometimes abdominal symptoms like pain and nausea and vomiting. You may elicit salt craving in about half of them. And interestingly, because of all this reason, because of this insidious onset, 40 to 50% do present with adrenal crisis as the first presenting clinical picture. And the diagnosis is usually clinched if you have a serum cortisol of less than 5 micrograms per deciliter, along with ACTH, elevated ACTH, typically which is usually more than 100 picogram per ml, which is measured either early in the morning or in a state of stress. On the other hand, if you have a serum cortisol of more than 20 microgram per deciliter at any point of the day, you can pretty much rule out adrenal insufficiency. In cases where the diagnosis is not so clear, where your reports are kind of borderline and in between, the gold standard is to go ahead and do a synaptin stimulation test. A peak cortisol response of 18 to 20 microgram per deciliter after the synaptin is considered as a sufficient cortisol response. And sometimes we do take a 2 to 3-fold rise from the baseline, or an absolute increase of 7 microgram per deciliter of cortisol is also taken as a normal cortisol response. And if you're suspecting mineralocorticoid deficiency as well, checking plasma renin activity is quite useful because PRS starts to elevate even before the electrolytes become abnormal. even in the early stages. So looking at the causes of primary adrenal insufficiency in children, this is not very recent, it's in 2005, where they looked at a 25-year experience of primary adrenal insufficiency, the etiological experience. Majority of them are late presentations of congenital adrenal hyperplasia, both in females and males. About 60% of them are some sort of congenital adrenal hyperplasia. About 12.7% are autoimmune adrenal insufficiency. And most of them are isolated autoimmune adrenal insufficiency. Some of them do happen as a component of autoimmune polyglandular syndromes. About 4% are adrenal leukodystrophy, which is presenting as Addison's disease for the very first time. And a small group, around 3%, are syndromic causes, like syndromes like Wolman disease, AAA syndrome, the alacrimia, adrenal insufficiency and eclampsia, and Zellweger's disease. So how are we going to approach? I'm going to briefly go through this slide before going ahead and revealing what we have in our child. So any child coming with the primary adrenal insufficiency, we need to rule out CAH for obvious reasons, because CAH is still commonest cause of primary adrenal insufficiency. So you look at the genitalia in a boy, you need, if you're noticing any precocious puberty signs, or in a girl, you're noticing any ambiguous genitalia, that will be your clinical evidence. Even without clinical evidence, it's a good idea to get a 17-OHP level. So if you have an elevated 17-OHP, you would evaluate in terms of CAH. If you do not have any evidence of CAH clinically or biochemically, you may want to look at any evidence of adrenal leukodystrophy. You can consider doing an MRI or very low chain fatty acid levels in the serum, and also look for signs of associated, any features of associated other autoimmune conditions, which would fit the child into autoimmune polyglandular syndrome. So that would be hypothyroidism, any evidence of hypothyroidism, any evidence of hypoparathyroidism, or mucocutaneous candidiasis. And if you're noticing any signs of dysmorphism or genital abnormalities, you consider syndromic causes of adrenal insufficiency. Like in image syndrome, you have genital abnormalities. In AAA syndrome, you have alacrimia and eclampsia. In Wolman's, you have adrenal calcifications. And in adrenal hypoplasia congenita, congenital adrenal hypoplasia, you have hypogonadism. So these are the pretty much common, these are the areas where we need to evaluate in terms of etiological diagnosis. So in our child, the genital examination was not done in the emergency room. So we had to do it again, and genitalia were absolutely normal, prepubertal. He did not have any history or evidence of mucocutaneous candidiasis. His calcium and phosphorus levels were normal. Thyroid profile was normal. 17-OHP, we have done it despite normal genitalia, and that was normal. Ultrasound adrenal was normal, no calcifications, no enlargement of the adrenal. Because MRI was available, it was done, there was no evidence of leukodystrophy. Because VLCFA estimation was available, but it is costly, and exome sequencing has easy accessibility and has wider applicability, where you can look for genes associated with APS as well, autoimmune polyglandular syndrome. We had decided to send a genetic testing as a first investigation. The child was discharged on 9 mg/m² per day of hydrocortisone, 100 microgram per day of Floricort, with free availability of salt in the diet, and with written adrenal crisis management plan and an injection of hydrocortisone in the hands of the patient. So very quickly in the next couple of slides. So how are we going to manage a primary adrenal insufficiency? Essentially, we're going to replace glucocorticoids and mineralocorticoids. The dose of hydrocortisone is quite low in case in non-CAH PAI, close to 8 mg/m² per day. Whereas we all know that supraphysiological doses are required in CAH to suppress the excess androgen production. Floricort is often needed in most of these children. The dose can vary between 50 to 200 microgram per day as a single morning oral dose. The goals of treatment are reducing the signs and symptoms of adrenal insufficiency and promoting normal physical as well as pubertal growth to prevent the development of adrenal crisis, and in CAH, of course, to reduce the excess androgens. How do we monitor the treatment in these children? Monitoring is essentially clinical. So we're going to monitor the child for normal growth, weight gain, general well-being, and the least minimum dose that is required to control the symptoms is given in non-CAH adrenal insufficiency. There is absolutely no role for estimation of cortisol or ACTH. If you are attempting to achieve normal ACTH levels with a replacement, we'll end up with chronic over-replacement. Essentially, the adequacy of hydrocortisone is assessed predominantly only by clinical assessment. There is some role for laboratory investigations for assessing the adequacy of mineralocorticoid replacement. So we do check blood pressure on every visit, electrolytes, and plasma renin activity once a year, once in 6 months to 1 year. Aim for normotension, normokalemia, and PRA in the upper normal range. And the most important aspect is to prevent the adrenal crisis. The incidence of adrenal crisis is very high, 5 to 10 in 100 treatment years. And mortality is almost close to 10% of all the presentations. So written instructions of the sick day rules have to be given to the parent, an emergency glucocorticoid injection kit, and how to do the self-injection has to be trained. Any child who's on corticosteroid replacement for any reason, not just for adrenal insufficiency, for any reason for that matter, who's on good dose of glucocorticoid replacement, with febrile illness or diarrhea or vomiting, especially with inadequate oral intake, they have to triple the dose. The minimum dose of 30 to 50 mg per meter square per day of hydrocortisone has to be given. There is no need to increase the mineralocorticoid dose because the hydrocortisone provides a certain amount of mineralocorticoid action as well. If the child is unable to tolerate the oral therapy, if there is any vomiting, it's essential to give the intramuscular hydrocortisone, 50 mg per meter square, preferably at home. Half of our parents do manage. Sometimes they do carry the injection and request the RMP or local nurse to administer the injection at home, and then immediately seek hospital attention within 6 hours of the injection. And for major surgical procedures, we should not forget to give the stress dose steroid 50 mg per meter square at least 30 minutes to 60 minutes before induction. And we can repeat the same dose in divided doses 6 hourly. This dose can be halved in the second day, and maintenance dose can be resumed if everything goes well post-operative. And the final slide, what if the child ends up in adrenal crisis? So essentially, this is how our child presented. So we need to counter all the electrolyte abnormalities and hypoglycemia. So the primary most important thing is, in addition to hydrocortisone, giving dextrose and saline, and stress dose hydrocortisone 50 to 75 mg per meter square, intravascular or intramuscular. We should not delay the administration of hydrocortisone if IV access is not available. So go ahead and give it intramuscularly. And the same dose is given as an infusion or in divided doses for the next 24 hours and titrated as per the response later. If hydrocortisone is not available immediately, one can give methylprednisolone or dexamethasone. It's better not to give prednisolone because of the first-pass metabolism in the liver. So this is essentially the final message, trying to prevent the adrenal crisis. And if adrenal crisis comes, identify it early and treat it with an immediate dose of hydrocortisone and IV fluids and dextrose. Thank you.
Thank you very much, madam. It was such a very nicely evaluated and managed case. I think the message is catch them early, catch them before they develop an adrenal crisis. And number two, primary adrenal insufficiency is the tip of the iceberg. It's very important that we go to the root cause of the underlying pathology which is responsible for the same, which can have both therapeutic and legal implications. For example, if the child has adrenoleukodystrophy and you catch them before they develop neurological symptoms, it would be very pivotal for you to save them by doing a stem cell therapy or something like that, and saving their future as well. And so that is very important. They're very important to give them just physiological replacement and not higher doses, as in the case which you very beautifully summarized in your case, that children with primary adrenal insufficiency require much lower doses compared to those with CAH. Thank you very much, ma'am. There are no questions as such.
Just a second.
Yeah.
Dr. Shirisha, I request you to tell about your national level work. Madam has done a beautiful congenital hypothyroidism video in Telugu and many other languages. And also she is doing a lot of work on diabetes. And we are upcoming with one more conference with IAPTCB, and she has done many workshops for the pediatrician. Just in 1 minute, madam, in short.
Regarding the hypothyroidism, you mean?
Yeah, hypothyroidism and your ideal and your upcoming program of adolescent conference.
Yeah. Thank you, Amarnath. So hypothyroidism, we have come up with the help of GPED, which is Global Pediatric Endocrinology and Diabetes. It's a society based in Vancouver. With the help of Novo Nordisk and GPED, we created public health awareness videos in Telugu, English, and Hindi and Tamil. They are available in the YouTube. They are available in ISPE YouTube channel. We would like all the pediatricians to search for them, go through, and they can play them in their waiting rooms if it is possible. And if anybody wants to play, they can contact me, and then I can provide with the videos. And secondly, IDEAL is ISPE's Diabetes Education and Learning Program. This is the goal of starting IDEAL is to create a pool of diabetes educators for pediatric diabetes. We are doing 2 programs for diabetes educators per year, and 1 program to educate physicians dealing with children with diabetes, which has started only yesterday. The first batch of physicians batch of diabetes educators has started yesterday. And more information will be available in the ISPE website, ispe.org.in. And thirdly, we're going to have this Adolescent Endocrinology Symposium on 26th of June. All of you are welcome. Please register. We will send the registration details in the IAP WhatsApp group. We are doing it in association with IAPTCB. Yeah, thank you. Thanks, Amarnath.
Thank you very much. Over to Hemchandra, sir.
Yeah, I think the fourth and the most interesting case is to be presented by Dr. Bharat. He's
Dr. Rahul Reddy.
Sorry.
Yeah.
Dr. Rahul Reddy.
Yeah, he's
Sir
the most...
is a pediatric endocrinology consultant at Paramita Hospital and Fernandez Hospital.
Yeah, very young and dynamic pediatric endocrinologist.
Thank you, Hemchandra sir, for the introduction, and Amarnath sir. And I take this opportunity to thank Bhaskar sir for inviting me to the symposium today and his IAPTCB team. So I thought I'll present an interesting case of precocious puberty today. And a lot of times the interest is towards girls developing early puberty, but I wanted to tell this tale of a tall boy, which is also quite commonly seen by us, and it's quite commonly missed by a pediatrician and in general practice. So I got a 4-year, 11-month-old boy who had complaints of excessive height gain over the past 1 year. And then they also noticed pubic hair appearance and also penis size increase over this past 1 year. And he was also comparatively tall when compared to his others of his age. So these were the main complaints which parents come with, that he's growing very tall, he's taller for his age, as well as a little bit of hair development in the pubis area, as well as some may notice the penis size to be increased. Rarely also there are spontaneous erections which parents notice or the boy complains of when in this condition. And this child was born at term gestation by normal delivery with a good birth weight of 2.9 kilos. There was no family history of any genital ambiguity or early neonatal deaths or adrenal disorders in the family. Now, on examination, we can see that the penis length is very much increased for this age, is 8.5 centimeters, and the testis volumes were quite small at 2 ml when measured with an orchidometer. And both the testes were descended, and there was no hyperpigmentation of the skin or genitalia, and there was significant acne and oily skin for this child. So when we see such a child with signs of early puberty in boys, then what we do first is we look at the LH, FSH testosterone levels, along with doing 17 hydroxyprogesterone levels. And as suspected, because of the small testes and peripheral precocious puberty, we found a high 17 hydroxyprogesterone level in this child. Also, the testosterone level was high, and the LH, FSH was suppressed. So that again indicates a peripheral cause for the precocious puberty rather than a central cause. In addition, this child also had high serum androstenedione levels, also DHEAS was high. Now, when we see such children, we also do beta HCG to rule out any HCG secreting tumors, which was done to see if it was normal, and it came normal. And the worry with these children is when they have now we know the condition here, what we're dealing with this high 17-hydroxyprogesterone, high testosterone, and the suppressed levels is a simple virilizing CAH in this child. The worry is that these increased hormone levels at an early age, the sex steroids, cause advancement of bone age, and then they end up being short as an adult due to early bone fusion, although they're tall now. So how is this child treated when they have this condition of simple virilizing CAH? So steroids, so this child was started on oral hydrocortisone, 20 mg per meter square per day, and dose was adjusted as per subsequent lab reports and brought down. And this child also was started on fludrocortisone, 50 microgram once daily. After 3 months, when we found that there was elevated plasma and activity levels for this child, and to reduce the oral high-zone dose, this was added to. Now, this child, 10 months after diagnosis, we found on serial examination that the testicular volumes also started to increase, and it increased to 4 ml bilaterally from the initial 2 ml. And then this condition where the testicular volumes increased to 4 ml, so that's when we suspect central precocious puberty in such children, and which was confirmed again by doing the GnRH agonist stimulation test. And the reason for CPP, the central precocious puberty in these children with SVCH, simple virilizing CH, is due to triggering by a sudden drop in androgen levels upon starting treatment after the chronic elevation being there for a long period. So for that, this child again needed treatment with GnRH agonist treatment for managing the central precocious puberty so that the bones don't advance further and the height doesn't get limited. And as we know, this child came in at 4.5 years or so, and now 6 years, 8 months, the bone age is, after the treatment, these about 2 treatments, the bone age was 14 years, and it was advancing. The predicted final height using the Bailey-Pinu method was 143 centimeters, comparatively short compared to genetics. And as a last resort to improve the final height and optimize the remaining growth, in spite of the prior 2 medications, growth hormone therapy was also suggested to the parents in view of the predicted final height being short. And with this, there was some amount of increase in height velocity as well. So these are the various medications which have been used in these children to optimize the growth. So here you can see a graph. At diagnosis, the child was tall and more than the 97th centile. And here, after starting the steroids, the GnRH agonist was started here. And later on, growth hormone was started here to optimize it better. Now, this is the learning points in such a case is that prepubertal testis, that is testicular volume less than 4 ml, when in case of precocious puberty in a boy, then we should think of peripheral cause of precocious puberty. And whereas if there's enlargement of testis, it is due to central cause of precocious puberty. So if we have an oxidometer, so we can use that to measure the testicular volumes and understand if it's prepubertal testis or testis enlarged and pubertal. However, there are 2 caveats to this rule. Pubertal size testis can be found in 2 distinctive causes of peripheral precocious puberty. So the testis size may be increased in these 2 conditions of peripheral precocious puberty, one of them being the HCG secreting tumors of the testis, and the other being the genetic form of testotoxicosis. So important to remember these 2 conditions, and testicular volume measurement is important. Now, coming to the primary diagnosis, which is simple virilizing CH here, it is often delayed, the diagnosis is delayed as they do not present with salt wasting early on in life, but that late delay in diagnosis can cause very much advanced bone age at the time of diagnosis. So recently, another child came in at 9 years or 7 years, and the bone age was already 16 years. So there, you don't have much options for treatment. So it's a very late diagnosis. So early diagnosis, early investigations, and early treatment will help in preserving the final height in such children. So peripheral precocious puberty at an early age is seen at an early age, and then they can go on to develop central precocious puberty due to the androgen activation of the HP axis. And this again exacerbates the premature epiphyseal fusion, and then leads to a final short height. So again, this case is to highlight the importance of early diagnosis of simple virilizing CH, as late diagnosis often leads to poor height outcomes. Thank you. So this is quite common, not very uncommon. And newborn screening has helped us in identifying these cases early. And also if the siblings with CAH, then with the salt wasting CH, then these children can be screened early and identified, and it helps in better management of such condition.
Thank you very much, Dr. Bharat. I think I am reminded of the story of the rabbit and the tortoise. These boys and girls with precocious puberty, they land up as very tall children, like the rabbit. They go fast, and they ultimately sleep in between, because by virtue of their advanced bone age, they go in for a sleep and they stop growing. As in your case, you had to give them growth hormone to push their final height. So the message from this case is, I think it's very important that examination of the genitalia as per the IAP growth monitoring guidelines should be performed by all pediatricians, and pick up early cases of precocious puberty before their final height potential is compromised and underlying pathology is missed. There are no questions. And congratulations for the excellent case.
Thank you, sir.
Thank you, everyone. Dr. Rahul is doing lot of work in YouTube, Telugu education. Can you tell about your work in YouTube and all? Just Rahul. He's a young and dynamic, available for all the pediatricians. Please.
Yes, sir. Yeah, so I have been trying to put on some interesting diabetes education videos on YouTube, and also trying to disseminate them to increase the knowledge among pediatricians. And thank you, sir, for the encouragement from your side and all the other doctors, Dr. Linita, Dr. Sirisha, Dr. Bhaskar, and hopefully, yeah, I'll do even better work in future. Thank you so much.
Thank you all. We thank Dr. Leena Priyambada, Dr. Kavita Sakumari, and Dr. Kishore. They are also very leading pediatric endocrinologists. Because of the short time, we were unable to do, but we thank for them giving this opportunity. And once again, I thank Sunkush Bhaskar sir. Almost our strength reached to 100. In between, it was fluctuating. So thanks for the all viewers for your encouragement. We thank you all. I especially thank Dr. Hemchand sir, Linata madam, and the Riyad sir for troubleshooting. If Raghupati sir can give one or two remarks, and Dr. Linata Reddy will tell one or two words. They are the seniors. Over to you. Dr. Linata, you are there?
Yeah, I'm there.
Yeah, please.
Dr. Raghupati sir is there.
Yeah.
Dr. Raghupati sir.
I don't know whether sir will be able to ask. You speak and then we'll see.
Okay. Well, thank you to the organizing team, and thank you, Amarnath, as well. It was a very good presentation. I missed the first initial part, but then caught up. Anurag was midway through Anurag's presentation. It was really conducted well. And I think the last hour of case discussions, I think giving a variety and actually telling that the different ways children can present with endocrine conditions and how they can be missed were highlighted. So thank you, and hopefully we'll have more sessions like this in the future.
Thank you.
Good morning, everybody.
Thank you so much.
I'm really happy that I was able to listen to all the lectures and the case histories, and I could not shut off the screen or shut my eyes or block my ears, because the program was so wonderful. And I'm just recovering from a viral illness, but after the program, I think I'm almost back to normal.
Yes, sir. Thank you, sir. Thank you so much.
Learned so much. There is always lots to learn. Learning has no end. And I think I shall be ready for the next program if you are organizing.
Yes, sir. Yes, sir. Definitely, sir.
And my hearty felicitations to Dr. Bhaskar,
Thank you, sir.
Dr. Sri Krishna, and Amarnath, especially, for organizing this and for all his enthusiasm and interest. I'm sorry I was not able to speak, but I'm very glad that I didn't miss anything. Thank you.
Everything was your blessing, sir. Thank you so much.
Thank you.
Over to Bhaskar, sir.
Yeah. Thank you, Dr. Amarnath. Dr. Raghupati sir, you didn't miss us, but we had really missed you, sir. You are the champion of this symposium. You are the legend, and you are supposed to lead the symposium. But we are happy that your health is getting stable, and scientifically, again, science had stimulated or made you more healthier. Thank you for your closing remarks, sir. In future, definitely you will make use of your expertise for our branch and for our members. So kind of you for coming on the screen and giving encouragement.
Thank you so much.
So nice. And my special thanks to our strong opening batsman, Dr. Anurag Bajpai. Dr. Leenata said she missed really, I think somebody might feel for missing it. It was an excellent presentation about thyroid function test, and there was so much interaction, and it was very much expected from Dr. Anurag Bajpai. And Dr. Riaz sir, your presentation was so lucid and very understanding and crystalline on congenital hypothyroidism. Thank you, sir, for your enthusiasm for staying until the end of the symposium. Dr. Hemchand Prasad sir, you are so young, you are looking like a PG. I thought your picture was a little directed towards middle age, but your appearance on screen today is just first year PG student. But you made a tough topic that is hyperthyroidism, a simpler one and understandable to all of us. Thank you, Dr. Hemchand. And our faculty from Hyderabad, Dr. Leenata, L stands for leadership. So Dr. Leenata's presentation was very short but crispy and short stature. Maybe she thought she should make it very short because of short stature presentation. And Dr. Amarnath, thank you. You're always ever smiling, spiritual, giving science and as well messages every day and also during the symposium. You're very well covered the relevant topic, a plethora of cases of obesity. Thank you, Dr. Amarnath, for taking forward this symposium. And he was really involved in this since last 4 weeks. Please believe me, it's a fact. He was involved in this organizing, getting the legends, getting our Hyderabad leaders. Thank you, Amarnath. And Dr. Sirisha was given a little tough topic, but she made so well, and it's an elaborate presentation on adrenal insufficiency. And last, but very important, as Amarnath said, the youngest of all the endocrinologists in Hyderabad spoke so well about precocious puberty. I'm happy that he's with us at Paramita, and we appreciate his social services. On top of this, last but very important is special thanks to the participants. On this this link, there were more than 90 persons, and on YouTube, more than 250 persons. It shows the interest and anxiety of the PG students, practitioners to impart your knowledge and skills. So on behalf of entire Iaptcb EB, I thank you all, sir, and in future, we'll make use of your expertise and we'll stimulate and educate our members. Thank you once again. Namaste.
Thank you all.
Thank you, sir.
Thank you.